Fine. Good afternoon, Rangarajan sir. It's really great to see you here. And
Good
I'm so
afternoon, Lakshmi.
happy that we are sharing the platform together, sir. Such an honor to have you with us here, sir.
Thank you. Thank you so much.
Yes, Sonal. All fine, beta. Good to see everybody.
Thank you.
Waiting for the third season.
Yes, sir. Thank you so much, sir.
And
And
best of
thank
luck
you
to
for
you.
all the support. Thank you so much. And I guess, Dr. Nooral, we are good to go. YouTube live on.
Yeah, Dr. Sonal, we can start.
Okay. Good evening, everybody. This is Dr. Sonal Yerpude, welcoming you all to third season of International Orofacial Pain Congress in association with MedSkills and National Health Academy. This is our third year together, and the theme behind this congress, as usual, is only one thing: standardization of care for orofacial pain. We orofacial pain specialists, I have seen so many cases that have had so many multifactorial, multifaceted, and confusing diagnostics. So that this was the thought process behind we starting this congress, that we need to have some amount of standardization of care and awareness amongst our fellow colleagues and amongst ourselves. I have been learning from Dr. Davis Thomas, from other mentors, and from everybody. Each of my patient, I say always say that they are my mentors, but still I feel I'm at the tip of the iceberg because this field is so vast and so confusing. Today itself there were 3 misdiagnosed cases, and the diagnosis have changed after taking a thorough history. So every day we are learning. The learning curve is very steep here, and the theme for this congress this year is management skills. So we are here to give you all a good introduction into orofacial pain practice, how it is going to change your practice, as well as how you plan to manage these cases at a limited level, or how when to delegate and what not to do would be our theme, or would be our motto behind telling you all to understand that these cases are can come under the realm of dentist and when to delegate these cases. So the theme being what not to do. With that theme, I would like to inaugurate our function, and let me talk about some things have to be spoken about the whole team behind the Congress, that is International Orofacial Pain Congress, MedSkill and National Health Academy. MedSkill is a dedicated healthcare education and professional development platform headquartered in Delhi, committed to advancing clinical knowledge and skills among medical and healthcare professionals. It serves as a dynamic learning ecosystem, offering expert webinars, live interaction session, and structural educational program focused on current evidence-based practices across medical, allied, and health disciplines. Over the year, they have trained almost 5,000 healthcare professionals, and more than 200 global experts have been a part of MedSkill. National Health Academy need not say much about them because they are also based in Delhi, and they are a very well-known entity in terms of academics. And they are independent professional organization comprising experts from healthcare, medicine, social sciences, behavioral sciences, and this academy serves as an authoritative and imperative platform dedicated to strengthening healthcare system, advancing medical knowledges, and improving health outcomes. I would like urge you all to join the National Health Academy YouTube page and Facebook page to learn more about their programs. Over the year, they keep having, I guess, 6 or 7 such conferences, and they have a dedicated orofacial pain congress, which is dedicated to dentists, as well as there are medical professionals who are a part of our congress. With that note, we will be talking about orofacial pain and the practice more in the coming lectures and days to come. I would like to welcome the patron for this congress, that is Dr. Rangarajan sir. He is a well-known personality, and who needs no introduction. Professor Dr. Rangarajan is an eminent prosthodontist and orofacial pain specialist based in Chennai. He currently serves as a professor and head of prosthodontics in Shri Venkatesha Dental College, and is the founder president of Indian Orofacial Pain Association. Thank you so much, sir, for this privileged association. And it's a glad and proud moment for us to join this association. a distinguished academician. He is a leading author of the textbook of prosthodontics and has held leadership roles in Indian Prosthodontic Society. Since 1993, he has been successfully running a multi-specialty dental clinic in Chennai, integrating advanced implantology and orofacial pain management. Sir, I was in school that time, 1993. This seems like ages behind, like decades behind, and your contribution to Prosthodontic Society and now the Indian Orofacial Pain Society has been immense. And on that note, let me welcome you all as the patron for this Congress. And please, if you can just with few words of encouragement to our participants and as a mentor guiding them towards this whole specialty, and also speaking about Indian Orofacial Pain Association. So the stage is all yours, sir. Welcome, Dr. Rangarajan.
Thank you, Dr. Sonal. Really appreciate your invitation, and I'm really glad to be here at Orofacial Pain Congress that you have put together, you and your entire team. Highly appreciable and remarkable that you were able to get together so many wonderful speakers from not only from the national forum but also the international arena, and you also addressed quite a diverse range of topics, which will probably give anybody who's coming to attend this program an insight into what exactly this ocean called orofacial pain is. This is a type of a specialty where the more we learn, we realize how much we don't know. That is the kind of specialty that this is. And you yourself said that, orofacial pain, today you had a few cases, and only after you went back into the history, you were really able to do something. That is the key here. More than the hand skills in this, more than your hands, we need our eyes and ears to function properly. Just listen to the patient, the history taking, and the clinical examination is so vital to a proper diagnosis. And of course, the management, certainly, now we are getting more and more what should I say, consistent with what needs to be the management, not treatment. We really cannot treat most of these patients. We only like to manage. And with this in the background, because many of us are getting trained in orofacial pain as a specialist, and some of us in the country are, and I have to say that there are many who have already been practicing as an American board diplomat. Dr. Ruchika is here, Dr. Maithili. Many have been here for over 10, 15 years practicing this specialty. But some of us felt that this is a high time to start an Indian Orofacial Pain Association, which will certainly give more credibility and credence to not only education, but also, evidence-based management and treatments, and bring together everybody and see, finally, at the end of the day, we want the patients, the everything that we learn should be able to be transferred to patient care. And that is most important. We see so many of these patients roaming around with pain, chronic pain for so long. So really appreciate your team, and I'm very, very happy to be here and associated with you and your team as a patron for this Congress. And I declare this a third International Orofacial Pain Congress open. And I wish this Congress all success, and I'm sure it is going to be a wonderful learning and education period for whoever has joined this program, and I'm sure many are going to join. All the very best to you and your team. Thank you again.
Thank you so much, Dr. Rangarajan. And as likely they say, that we always begin with the blessing of elders and God and our parents. So, on that note, with the blessings of Almighty, all the surrounding entities, you believe in God, you don't believe in God, but take their blessings. And with their blessings, I would like to start with our third International Orofacial Pain Congress. And thank you, Dr. Ratin Das sir, Dr. Rangarajan sir, Dr. Ruchika Sood, and many other pioneers who are here today to be a part of this forum. Because I'll tell you one thing, sir, what really made this Congress also special is just 15 days, and it took me just one phone call to manage everybody to say, so I'm managing this Congress, so please join me. And Dr. Rangarajan was kind enough, you tell me when to join, I will join. So this is the kind of dedication and passion for spreading the true and correct evidence-based knowledge is in all of us, and that is the theme for this Congress. Pain is never confined to the body alone. We all believe that. A mother who delivers a child always wishes that the child should have a healthy, happy life. Imagine that mother seeing this child suffering through orofacial pain or any amount of pain. So, as a pain management specialist, the responsibility that we carry, we have seen cases wherein these patients are suicidal, wherein we have had to intervene, wherein we had to talk to their family members. And imagine a child who is being taken care by the mother and then sees the mother going into pain so much so that the mother becomes suicidal also. So you, this pain forum is, it's the whole study of pain management is very, very life changing for us as pain specialists. And I urge you all, if you all don't have a iota of empathy or sympathy in you, please do not even start this practice, because I will tell you one thing, that if I have learned something to become over a period of time as an orofacial pain specialist, my take home message will always be, learn that this can be your story too. So don't ever lose that empathy quotient in you. Be empathetic, be human, understand that no, none, if the patient is saying if they are in pain, take it for that they are in pain. Understand their pain as your pain. Today you are sitting on this side of the chair, tomorrow it could be you who stand sitting there, or your family member could be sitting there. So with the note of empathy and blessings of our elders and all our the gods or whoever you trust and believe in, we start with our first speaker, Dr. Dr. Bhagya Lakshmi Avinash. Dr. Avinash, are you there?
Yes, I'm here.
Yeah. Dr. Bhagya Lakshmi Avinash, can you just smile for the camera?
Yeah.
1 second. Okay. And as is the ritual with all the speakers, I will be asking them to smile for the camera. That will be my selfie mode with the speakers. Secondly, I would ask you one question. I had given you all a sheet wherein I will be asking one question, and all the speakers Q&A will be answered in the chat box only. Okay. So I urge all the participants, welcome to International Orofacial Pain Congress, and you all can ask all the questions pertaining to the topic to the speakers in chat box. None of you should unmute their mic, because it will be very disturbing to the speaker as well. Don't speak in between. You can ask in chat box. Okay. Okay. On that note, let's start with our first speaker, Dr. Bhagya Lakshmi Avinash. She is a prosthodontist professor and FAIMER fellowship. She's completed IFACE fellowship with extensive experience in Invisalign and airway focused orthodontics. She is widely known for her pioneering work in interprofessional collaborative care, leading interdisciplinary initiatives that enhanced patient-centered outcomes. She has been an invited speaker at numerous national and international platforms and continue to drive innovations in collaborative healthcare. Dr. Bhagya Lakshmi A is an orthodontist professor, and she is also a very well-versed speaker. Dr. Bhagya Lakshmi, my first question to you would be, what soft skill do you think as a orofacial pain or pain management specialist every individual should have?
Communication.
Oh, wow. Lovely, lovely, lovely. Yes. Okay, your screen is visible, doctor. You can start your presentation.
Thank you so much. A very good afternoon, everyone. It's an honor to be here at the International Orofacial Pain Congress. Today, I'll be speaking on a subject that has shaped my clinical philosophy, interprofessional management of orofacial pain, or what I call wearing many hats, because in the world of chronic pain, one hat is never enough. I have a little disclaimer. My session will not deal with what is orofacial pain, what is the etiology, all that. I would like to introduce a different kind of approach to manage orofacial pain, and I hope that will help everyone. So before we get into my session, I request everyone to take a moment and reflect on your experience. Reflect where you felt, I wish I had learned or worked alongside another professional to execute a skill or deliver service more effectively rather than learning or working alone. Dear everyone, just take a moment and reflect. Have you ever felt that while treating your patient, did you ever feel that, if I had worked with another professional, maybe I would have given a better service? Or when you were learning something, You felt that, if I had learned alongside another professional, I would have understood this concept better. So if you have ever felt like that, please put an S in the chat box. If you do not want to put in the chat box, it's okay. But the important thing is that I want you to reflect on this. So with that note, I would like to begin with a story. A 34-year-old woman walked into my clinic with tears she wasn't trying to hide. She had visited 6 specialists, a dentist, a neurologist, a psychiatrist, ENT surgeon, physiotherapist, and finally an occult healer. 6 specialties, 5 prescriptions, 0 relief. She said, "Doctor, the pain is killing me, but the confusion is killing me more. Everyone says something different. I don't know who to believe." In that moment, her pain was not biological, it was emotional, social, and psychological. That day, I realized it wasn't her body that was failing, it was a system. She didn't need more reference, she needed clarity. She needed collaboration. She needed an interprofessional team that spoke one language. So today I want to take you all through why wearing many hats is no longer a luxury in healthcare, but it's a responsibility. Orofacial pain is incredibly common, but its complexity makes it one of the most misunderstood conditions. It's chronic disorder. It behaves differently, presents differently, and demands a very different style of thinking. It's multifactorial. This sets the stage of why traditional approaches fall short. It's very challenging. Why? Because this isn't a simple toothache. Orofacial pain overlaps with neurology, psychology, musculoskeletal medicine, and dentistry. Etiology is rarely singular, usually a combination of interconnected factors. Prevalence being nearly 70% in adults. No wonder patients end up seeing multiple specialties before receiving relief. What is the reality today? This is the reality. Referral carousel. Patient moving from one professional to another. As a healthcare professional, we often tell that, patient is going doctor shopping. But if you really think into it, is it the patient who is doing that, or is it because of us they are doing that? Patient going from one room to another, one professional to another, or one building to another. That is a referral carousel. Patient moving from one professional to another, each seeing only a fragment of the puzzle. This delays diagnosis, increases frustration, and weakens the trust in the system. To help you all understand what I'm really meaning here, I would like to introduce a clinical scenario, a common clinical scenario. Now, this is a multi-specialty hospital ward. Here, Mr. Prabhakaran has got admitted since a week because of stroke, and there is Mrs. Prabhakaran. It's 9 a.m. and the physician comes for, rounds. He comes and he asks, he checks Mr. Prabhakaran, and Mrs. Prabhakaran asks the doctor, "Doctor, when will he start walking, talking, and eating like before? I cannot see him like this anymore." And the doctor says, "Ma'am, I have informed you before about the effect of stroke on his brain. His recovery will take time." Or the occupational therapist, speech language pathologist not coming for therapy? What are they saying? It's 10 a.m. Nurse comes. And Mrs. Prabhakaran says, "Doctor had told us to stop this medicine from today." And the nurse says, "Oh, I'm unaware of any such instruction. Maybe the nurse on the night duty knows about it." It's 11 a.m. Dysphagia therapy. And Mrs. Prabhakaran asks the therapist, "The dietitian told us to give him chapati from today." And the therapist says, No, his oromotor system is not yet ready for solids. He may choke." 12 p.m. Food and nutrition specialist has come. And she asks, "Mr. Prabhakaran, how many chapatis did you eat today?" And Mrs. Prabhakaran says, "The speech therapist said that he is not ready for chapati. They say that he may choke. Why don't you talk to her?" It's 2 p.m. Occupational therapist has come and Mr. Prabhakaran is very tired. And Mrs. Prabhakaran shares the concern that he's too tired to do these exercises. But the therapist says, I have been asked to do so. He has to do it. 3 p.m. physiotherapist has come. And Mrs. Prabhakaran asks, how are these exercises different from what the other person did? Why so many of you come? 4 p.m. speech language therapist has come. Mrs. Prabhakaran asks her, when will he be able to speak like before? He's just not improving. And the therapist says he's always too fatigued after physiotherapy. He needs to cooperate for speech therapy. At the end of the day, Mrs. Prabhakaran is so disappointed and so sad. And she says, it has been so many days here, nobody tells clearly when we can go home. I'm worried about the hospital bill. And all what Mr. Prabhakaran can say is, I want to go home. I want to go home. So dear everyone, I request everyone to take some moment and reflect what's going on here. Why is that Mrs. Prabhakaran so disappointed and sad? In spite of Mr. Prabhakaran being there in a very good hospital, in spite of the hospital having excellent services, in spite of the hospital having such skilled professionals, Mr. Prabhakaran is not recovering and Mrs. Prabhakaran is extremely disappointed and sad. Why do you think this is happening? This is happening because there's definitely no interprofessional practice. When there is no interprofessional practice, it leads to lack of critical information, misinterpretation of information, unclear orders on phones, and overlooked changes in status. When a system doesn't deliver results, we must question it. And if the patient continues to suffer despite multiple consultations, the problem isn't the patient, it's the fragmented approach. This is where collaboration becomes not optional but essential. So no single professional owns orofacial pain. We need neurologists for neuropathic pain, psychologists for behavioral contributors, physiotherapists for functional disorders, dentists for structural issues, and physicians for systemic causes. When we combine these insights, we truly serve the patients. I love what Henry's philosophy is. He says orofacial pain is not discipline specific. Dentists are often the first point of contact. But to help these patients, dentists must broaden their knowledge into neuroanatomy, psychology, and physiology. This mindset shift is the foundation of interprofessional care. In 2010, World Health Organization made a strong statement. Health professionals must learn with, from, and about each other. I repeat, health professionals must learn with, from, and about each other. And that's exactly what is interprofessional education and collaborative practice. Dentists should learn from, with, about medicine specialty, about nursing, about physics. Every professional should learn with and from about each other. This isn't just to improve our knowledge, but is to optimize patient outcomes. Orofacial pain fit perfectly into this model because no single profession can address all these dimensions. So let's look into some other systems of treatment for chronic disorders like orofacial pain. So we all have heard this term multidisciplinary, very commonly, used term. If you look at this is exactly what I explained in Mr. Prabhakaran's case. Patient is in the center. Every professional is visiting the patient and interacting with the patient. But if you look at the diagram, each professional is only interacting with the patient. They are not interacting with each other. Every professional is very diligently doing their duty. They are coming on time. They are doing their duty. What is required from their end, they are doing. But they are not interacting with other professionals. But for chronic health disorders, that interprofessional collaboration is required. This is interdisciplinary, a little upgraded approach compared to multidisciplinary. Here, patient is in the center. Every professional is coming and interacting with patient and doing their service. They're also interacting with other professionals. Now, this interaction with other professionals is happening once in a while only. This once in a while is happening when when they meet on the corridors, when they meet in the food court for coffee or tea, or when they meet in conferences. This once in a while interaction with other professionals is not structured and it is left to chance. But if you look at the interprofessional approach, here you see every professional is overlapping with each other as well with the patient. They're interacting with the patient, they're interacting with other professionals, and this interaction is not happening once in a while. It is a structured approach, scheduled approach, and they have a perfect time set for it and perfect moment set for it, and they all come together with the patient. They discuss together, they form one treatment plan, they form one diagnosis. There is a unified case sheet. This interprofessional collaboration is nothing new. It is very much existing globally. It is there in Canada. It is there in Australia, Japan, UK. It's very well practiced for certain chronic health disorders. But in India, it's still in infancy, and it is high time that we start this kind of an approach. So why IPCP matters in pain care? It's because chronic patients often hop between multiple clinics. Interprofessional practice aligns these perspectives so that patient doesn't get conflicting advice. It strengthens our communication, builds trust, and leads to more accurate diagnosis. A shared care plan is essentially a roadmap created together. It prevents overlaps, avoids contradictory treatments, and keeps everyone aligned. Most importantly, it ensures that patient stays at the center, not the specialty. So these are some of the core competencies of interprofessional practice, and these competencies form the backbone of effective collaboration. Mutual respect, clear understanding of roles, open communication, and strong teamwork. When these four come together, patient care becomes seamless rather than scattered. So you can see that the benefits of interprofessional collaboration, these are proven benefits, not theoretical. Better outcomes, improved safety, a happier workforce, a more satisfied patients. So interprofessional collaboration is not an experiment anymore, it is a necessity. So imagine instead of working in silos, we bring all the professions under one roof. Real-time discussions, shared insights, a coordinated strategy to diagnose and treat. And this is what finally breaks the cycle of mismanaged orofacial pain. We need to move from my patient to our patient. So what is the shift we need? This is the shift we need. We need the shift from referral carousel, from multiple referrals to multidisciplinary planning, from fragmentation to integration, from my patient to our patient, and that's how we deliver truly effective pain management. The future of orofacial pain is very clear. No more isolated decision making, no more referral loops. It should be integrated, interdependent, interprofessional care. It's smarter, faster, more scientific, and more humane. And it elevates our profession to a new level of responsibility and impact. So if you remember just one point from today, let it be this. Orofacial pain cannot be treated in compartments. When we collaborate, when we communicate, when we co-manage, when we commit to patient-centered care, we diagnose better, we treat better, we transform our patients' quality of life. Orofacial pain demands integration. So this is a picture of interprofessional collaboration happening in one of our settings. This is not a orofacial pain patient, but it's a similar kind of approach we are doing. This is an upper airway disorder patient. Here you can see those professionals sitting there are all different. There's one ENT surgeon, there is one orthodontist, there is a pulmonologist, there's a pediatrician. We don't believe in sending patients from one building to another building. We don't believe in sending patients from one room to another room. For such chronic health disorder, patient is at the center. We all professionals come together under one roof. We examine the patient together. We are learning with each other. We make one diagnosis. We make one treatment plan. And we do interprofessional collaborative practice. So, dear everyone, when we wear many hats together, we remove the heaviest burden our patients carry, and that is pain. Collaboration is not just a method, it's a mindset, and it's time we embrace it fully. Thank you, everyone. I hope you all understood what I was trying to explain. Thank you so much.
Yeah, thank you, Dr. Bhagyalakshmi. That was actually a very good start to our Congress, because this is what I was trying to emphasize all while, that empathy, understanding the patient and treating the patient as a whole, not only like, one or two symptoms. Thank you so much. And on that note, I would like to ask you one more question. One book, non-medical book, that you would like to say that has changed your way of thought process or maybe practice, whatever.
A non-medical book, The Secret by Rhonda. I just love that book because it talks all about manifestation and about positive attitude, positive thinking.
Great, great, great. That's actually I think I'm going to get this book's recommendation by most of the speakers here. Thank you so much, Dr. Bhagyalakshmi. And on that note, I would like to welcome our next speaker, Dr. Ramya. Dr. Ramya, are you there? Dr. Ramya is going to be talking about something about metabolic disorders, dysregulation in chronic orofacial pain. Dr. Ramya, are you there? Okay.
Hi, Sonal.
Hi. Hello, madam. Can you switch on your
Yeah,
camera, ma'am?
yeah. Just give me 2
Orofacial pain,
minutes.
orofacial
Right.
pain mirrors metabolic stress. And that's what Dr. Ramya is going to be explaining about. When energy pathways and inflammations are disturbed, distinct metabolic patterns emerge, guiding precise diagnosis. So, history taking, complete evaluation of the systemic factors, or complete evaluation of medication. You remember that in the first year or second year, when we started taking case history, and we were all clueless, why are we asking so many questions? Why are we digging into patients' case history so much? Why are we digging into their personal life so much? What have you eaten? What are your medications and all? So it all makes sense once you start practicing. And a good clinician is the one who spends time taking more of case history over investigating but under treating. So on and I would, as Dr. Rangarajan has also specified or mentioned, it's very important for us to understand the metabolic parameters that will definitely shape our diagnostic criteria and the way we manage our patients also. Dr. Ramya here is she is a very much a part of our Congress every year, and she is Associate Dean of Extension Activities and Professor and Head of Department of Oral Biology, Savita Dental College, Chennai. Madam, I must say you are your college is a very well known entity and a hub to become a dentist nowadays. And welcome, Dr. Ramya, and it's a pleasure always to have you on board. Dr. Ramya, the stage is all set for you.
Yes, Sonal, just a minute. Give me a minute. I'm just.
Yes, ma'am. Take your time. I would like to welcome all the participants who have actively registered for the Congress, and for your convenience and for everybody else, we are live on YouTube right now also, and the sessions will be live and active for almost 1.5 year post this session also. So you all can easily go back to any of your favorite lectures and revisit and learn from them. And in case if you wish to be a part of this Congress, please join the National Health Academy YouTube page and MedSkill YouTube page. So you all will know more and more about the activities that National Health Academy and MedSkills bring about. It is not just about Orofacial Pain Congress, Cancer Congress is also coming up in May. We have Pink Dental Congress, that is a very much all women Congress, and there we have all multi-specialty dentist, women dentist, who will guide you into entering a phase of life, I would say, with class and with dignity, with so much of enthusiasm that the year goes, we keep waiting for this International Pink Dental Congress, and everybody's all excited for this Women's Day Congress. And men are also welcome to join this Congress. So it's nothing, not the yes, the speakers are females, but men can come to encourage them. So, and the other congresses, I think Dr. Nooral will be a better person who will be able to guide you all, because he will be joining us at the end of the session. He will let you all know about the sessions that will be our planning in the next coming year. And National Health Academy, as I had mentioned, that they keep planning for, they are a medical team, but they have had a very special orofacial pain curiosity, or the team was very curious to know about orofacial pain's practice that can change or that can influence their practice as well. So it was a very welcoming thought when the medical fraternity wanted to know more about dental this practice of orofacial pain and collaborate in such a way that their practice is also enhanced and we also learned so much from them. So thank you, National Health Academy and MedSkills, and thank you to our participants who are right now also present here. And I would urge you all to ask questions to the speakers in the chat box so that you all don't miss out on any of the information which you all like to know. And we will urge all the speakers to answer all the questions as much as possible. I can
Thank
see
you,
more and
Sonal.
more
So,
participants joining. No, madam, no problem, no problem. Yeah, thank you, ma'am. Thank you, ma'am, for joining. And as the custom, smile for the camera, ma'am, please.
Just a
Okay.
minute.
Okay, again, okay, yeah, this says it all. Yes. Thank you, ma'am, so much. Ma'am, I would like to ask you one question. What is that? I think you've sent me a question also, what you want to know, but for my understanding, I would like to know which book has changed your life, like, what non-medical book which has changed your life.
Non-medico book which really made a very big impact on me was Ashtavakra Samhita by Osho. So
Okay.
that is like the Bible to me. So try, if you get a chance, please read.
I
It's
will
a life
definitely.
changer. Yes.
Okay, ma'am. The last time also what you suggested, I had already read that. So thank you so much. And thank you for being an active part of International Orofacial Pain Congress, Pink Dental Congress, and a team with MedSkills and National Health Academy. Welcome, Dr. Ramya. And the stage is all set for you. You may start sharing your screen, Doctor.
Thank you so much. Thank you. So I have 25 minutes, right?
Yes, ma'am, you have 25 minutes. And we are well within time limit, so no issues.
Yeah, that's really, that gives me a lot of relaxed mode. Anyway, thank you again. MedSkill, I think we've been from the time 4-5 years, I think, have been in most of your sessions, and thank you for that confidence and having given me an opportunity in every program of yours. It's a great feel to come back again in another event of MedSkill. It's so professionally organized. Thank you so much. So quickly moving on to the topic, I'm here to talk about metabolic dysregulation and orofacial pain. And is my screen visible?
Yes, ma'am. Please go ahead.
Okay. Can you see the second slide also? Is it changed?
No, ma'am. We are still on the first slide.
Okay. Is it now moving?
No, ma'am.
Uh-huh. Now?
No, ma'am.
Now?
Yes, ma'am. Introduction slide.
Yeah, thank you. Okay, so orofacial pain, I think Rangarajan sir had given a very good introduction, and I was here to listen to Dr. Bhagia's lecture, which insisted on multidisciplinary collaboration, and it was a very interesting perspective. So this is definitely a very complex system. So that is why we've done a lot of research on orofacial pain and what really instigated our research team to go into metabolomic aspect to orofacial pain is because in my 25 years of clinical experience, I could definitely relate a lot of psychological aspects to pain and pain perception. And that is what reflects in the classification systems as well. So I'm not going to go into the definition or classification because all of you know them. And this is something which all of you should understand. The prevalence of orofacial pain is on the rise, and that is why there is an exclusive event which is concentrating on pain. And when we know that the prevalence is really increasing and than what it was sometime before, automatically it triggers us, or it stimulates us, or creates a very strong urge that we should do something to treat it or prevent it. So that kind of urge is what made me into this direction of knowing the entire metabolic makeup of that particular individual and what exactly is going wrong. Are we only looking into very superficial indicators or determinants is what made me dig deeper, and that is how we started creating projects in this. And this is one short snippet of what we have studied so far in our department in oral biology at Savita Dental College. And that is what I'm going to share it with you. So why are we going to do metabolomics? Because metabolomics tends to give a very broad picture of what really underlies in every disease. It is not only for orofacial pain, it gives a very deeper understanding in every disease. If you really want to go into the depth and understand what really lies in the multi-system interactions, to understand what goes behind in understanding the dynamics behind the disease process. And once you start, or if you have that curiosity to know more, you also should be very relieved that all of them can be detected through any of the body fluids. So as dentists and oral healthcare professionals, the biggest asset for us is saliva. And all my results here, which I'm going to showcase, is all the results which we obtained from salivary metabolomics. So this is the biggest area which we are working on. And this data which I'm presenting here is case-based details about the metabolomic dysregulation in orofacial pain. So in pain, there is a imbalance in the homeostasis and in the metabolome as well. So most of the time we tend to treat pain on a superficial aspect in relation to symptomatic basis. And especially in a country like India, where impatience is too much, I would say every patient wants a shortcut, and that tendency or that urgency is becoming worse now. The impatience degree, I would say, it's been two decades of practice, and the level of impatience is raised, and that could also be one of the reasons why complexity is becoming even more complex. So anyway, having said all that, understanding the deeper note of what exactly is happening at the metabolic level is what triggered this study. So what we could see that there is a definite deregulation, and deregulation was found to be in multiple aspects. And we really are very confident about saliva because, again, I've been working on saliva for more than 1 decade now, and we've been finding very, very interesting perspectives to it. It's not only orofacial pain. I've established multiple biomarkers related to oral cancers and potentially malignant disorders as well. So we have done multiple approaches to check the proteome profile and multiple other biochemical profiles in saliva. But this system, which currently reveals a very high sensitive proteome profile, is time of flight mass spectroscopy, mass spectrometry. And this really works wonderfully with saliva. So any one of the postgraduates who are listening to me over here now, understand that this is an excellent method if you're working with saliva. It can either be MALDI-TOF or it can either be Q-TOF. So both these methods, the biggest advantage is they are label-free. And if you choose a label-free detection method, there are very, very many advantages. The precision of the biomarker discovery is amazing. And there are multiple cohorts on saliva, which we work on this perspective. So saliva, I don't have to talk about the advantages. Every one of us know. And this is our preferred body fluid, which we heavily rely on. And of course, every one of these study, we definitely compare them with the serum data as well. So the consolidated data for orofacial pain in terms of metabolomics is what I'm going to list out here. All you would see is a lot of names and names of enzymes, lipids, and metabolic byproducts. But this will give you an overview of how complex is orofacial pain. And that is why I insisted that I initiate this dialogue early in the event, in the first day itself. So this will trigger a lot of discussion. And if we can really come out with some meaningful conclusions at the end of the event, we can really plan in targeting these changes, these metabolites. And if we can derive some kind of pharmacotherapeutics, particularly targeting on these, then I really keep dreaming of preventive management as well. And orofacial pain is on the rise, and there is much more we need to know about this. So a quick look at the amino acid derivatives, which was found to be dysregulated. The most typical ones are the dopamine group and the glutamatergic group, which was the highly deranged group in terms of amino acid derivatives. And surprisingly, we also found fatty acid dysregulation on a higher note, was very, very significant next to the glutamatergic pathway. So this is again not reported data. So glutamatergic pathway we had reported earlier in a publication. This particular data is presented to the public through MedSkill event now. And most of the times, if you see fatty acid dysregulation has not been reported in orofacial pain much. So this is of great importance, especially when you correlate it with metabolic syndromes. Metabolic syndromes are the current, I would say, mostly discussed about topic. So India is in a pandemic-like state. I would say this might sound a bit it might sound like an overstatement, but the sad thing is, being a diabetic capital of the world, we are reeling on chronic metabolic syndromes. So fatty acid dysregulation again goes into a complex link of obesity and metabolic dysregulation and so on. So there is so many interconnected factors when you see fatty acid and lipid dysregulation in orofacial pain. So this was a very big surprise to us when we received the complete data of the QTOF results when we completed that study. And the next thing which was also dysregulated was mitochondrial acids. If you dig deeper into the mitochondrial pathways, most of them are related to the carbohydrate metabolism. So again, all of them are related to I would say again, metabolic dysfunction. Metabolic dysfunction is again a very broader term. To link them all to simpler terms, lifestyle modification is what we need. That is the inference to derive from seeing all these alterations related to mitochondrial acids. We have published a paper on mitochondrial dysregulation in oral cancers. But surprisingly, there were a lot of data interconnects between orofacial pain and the metabolic shift which we saw in that cohort as well. This might be too much to take in, but this is the sad state of affairs, and I would attribute that the common foundation to all this is the chronic inflammatory state, which is very, very important in chronic metabolic syndromes. And once there is a chronic inflammatory states in the body, there is dysregulation in top to bottom, and every organ is dysregulated. It's altered, and there is a dysfunction, and it starts giving out symptoms in the locations whichever is being affected more. For example, if the inflammatory mediators are becoming more concentrated in the muscles, for example, And we know that the orofacial muscles are the victims of overthinking. Simple term, the orofacial muscles are the victims of overthinking. A simple scrolling of the mobile phone can give too much of work to all the orofacial muscles, especially those surrounding the eyes. That is a trigger point, and there is a sequence of vicious circle which happens. So everything, if you see, it's all interlinked and correlated. And now what we can see is this chronic metabolic syndromes, they have a very big spectrum. So one end of it is cancers. I'm not trying to tell you that orofacial pain persons will have cancer. There is no correlation like that. We are surprised to see that the metabolic shifts, the metabolic dysregulation, many of them are appearing common. So the underlying reasons, if you can quickly read through the hallmarks of cancer, the current list was published in 2022. If that is being compared, and if this data is compared, then you would see that there are so many very critical points that we should take from all these points. And then the general ions like adenine, uric acid, nucleic acids, riboflavin, all of them seem to be dysregulated when compared with normal systems. And these are the enzymes which were found to be abnormally altered. So so what is this exactly suggesting? So once there is lipid dysregulation, as I already mentioned, it is actually trying to indicate that these are the ones which are modulating the TRP1 and the TRPA1 receptors, which are critical in pain and the pain perception. And we also have a paper on this TRP1 in oral cancer. That was actually a coincidence because that was published I think it was 3 or 4 years before. This data which I'm showing you right now is the recent data, just 1 year before. And when comparing the data, we found very interesting correlations. And these receptor linkage tends to promote peripheral sensitization, which is a hallmark in oral cancer. So now please correlate lipid dysregulation leads to nociceptor sensitization. So the receptors are becoming too sensitive. They are becoming overreactive. So where do we connect all these two? So the chronic metabolic syndrome is the problem. And this is where we should start working out from. So next time, if you have a patient, the patient needs a holistic approach. I kept hearing Dr. Bhagia's insistence on have a holistic approach or have a joint approach, and that was perfectly said. Additionally, I would definitely recommend more counseling, which the patient definitely needs from nutritional aspect also. Presenting you in such strong data, they also need nutritional counseling, in addition to bringing in all specialists under one umbrella to manage orofacial pain. And here again, if you see mitochondrial stress and energy reprogramming, everything relates to the dysregulated metabolic pathways. So all of them have a very important imbalance on the neurons and the glial cells as well. And further, we have these nucleic acid dysregulation. Just one word, if you want to know about what it does, it increases the neuroinflammation. So all the nerve tissues are becoming inflamed. So what would happen? The nerves would be in a constant state of pain production. So it would constantly keep telling you that there is a subtle degree of chronic pain happening. And what is causing this? It is because of the improper purine metabolism that leads to a lot of reactive oxygen species. And then there is NLRP inflammasome. NLRP inflammasome and all have been reported, like how we have TRP1. NLRP inflammasome is well known to be associated with pathophysiology of pain. And all of them put together, if you put them into a funnel and then derive the output, it would all be pointing out at a chronic inflammatory state. So that's very important. And then we also have steroid derivatives. So I don't have to emphasize on steroid derivatives. We know that the moment there is stress, then there comes cortisol, and we know how it goes and triggers the central pain pathways. And then we also have found that there is huge neurotransmitter imbalances. So all the amino acid imbalances, which are very, very important key regulators, all are dysregulated in orofacial pain. And these are very important to central sensitization and neurochemical imbalance in chronic orofacial pain. So they are very, very important. And again, coming down to the inflammatory activation, IgA was very, very prominent. That is because of saliva, and lysozyme again is a typical salivary enzyme, but most of them were abnormally altered, and that could also be correlated with chronic pain mechanisms. And this is something again very, very important. We know that the problem starts in overstretching, of course, overthinking manifesting as overstretching of the muscles. And that could also be found in our data, which the mass spec revealed. And this was very, very specific to conditions related to the myofascial problems of TMDs. And a quick summary of whatever I said, that saliva is a very simple way to understand the mechanisms which happen in orofacial pain. And this we have correlated with the serum, and the summary was what was exhibited here. So this integrated approach, to re-emphasize on the previous what the previous speaker said. So it is just not about prescribing a certain group of medications. It is the younger minds who are listening here to create some new therapeutic protocols to manage orofacial pain better. So this is an attempt to dig deeper, understand the pathophysiology of pain in a better way, create better therapeutic targets, and create better therapeutic regimens to handle orofacial pain better. I'm just dreaming of the next year, same time next year, if we could bring in a better protocol in management of orofacial pain with some advanced understanding. It would be a great thing to know about. So this is how we should approach orofacial pain, understanding its complexities. Thank you for your patient listening. I'm open to questions.
Thank you, ma'am. Thank you so much. As always, you have churned that rational wheel of thought process in us, and such a detailed study, ma'am. So, you have said that you have been into practice for the past 25 years. So, there must have been some mistakes or something that inspired you to change your practice into managing pain or becoming a pain specialist or changing your line of treatment. So, what was that instigated this whole habit, or maybe something that changed in you?
Yeah, thank you, Sonal. That was a very interesting question. We keep we keep getting patients having very non-specific pain over time. I've been seeing them for a very long time with so many years of experience. The first thing, if any patient says that there is non-specific pain, or if there is no teeth-related pain, I just immediately take some time to sit and talk to the patient. That is my first approach. Take a detailed case history, take a detailed report about slightly on their personal and professional history as well. So this started over, I would say this kind of questioning is very, very important, because once you start hearing to the patient, they will definitely put out some inputs which will automatically give you a psychological perspective. And most of the times, I don't know whether I can tell this out, I would do a lot of counseling to manage the psychological aspects, give them very simple exercises which have been really working well. And we have done a large scale trial with Davis Thomas sir is part of that study as well. We have a positioning of the lower jaw that was given to a postgraduate student, and we did a large-scale randomized clinical trial on that, just to avoid over-positioning of the temporomandibular joint. So that is yet to be published, so I will discuss that at a later point of time. So it is just not about pharmacological interventions. We also, I usually tend to tell them how to manage stress, and also tell them how to simple exercises, jaw exercises, which have really made a very big difference. So this kind of approach have really made people come back to me and then ask more help, and they used to refer patients who have such pain. And over time, I saw that the interest towards pain is very much increasing. And once facilities were there, we started digging deep, and that triggered us to know more about pain mechanisms. And that is when we started going deeper down at the molecular aspects of pain pathophysiology.
Thank you so much, ma'am, for this insightful day, the start of the Congress. And thank you so much for your insights also, because this history taking, as I was always mentioning about, or knowing more about the patient. More often we see that, if you have known me, I always say that every smile or every life has a story. So it happens so that when a orofacial pain specialist will always come across this sentence that, why am I not feeling better? Actually, that is more of a accusation at times, or more of a question or a helpless plea of the from the family members also. Like yesterday itself, I received a call from a person who was trying to help his wife in pain. She literally hits her head onto the pillow, or she is literally asking her son to sit on the head so that she feels better. And a little change in medication, and today she called me up saying that okay, she could sleep much better. So that one sentence of encouragement to us makes a lot of difference. But imagine a story of a family wherein the son is sitting on the mom's head, literally sitting. Actually, all the kids sit on our heads, we know that, but this child is sitting on the mom's head just so she feels little bit of pain relief. And the kind of diligence or kind of care we as pain specialists, or responsibility we carry, is multifolded when such patients walk in, or such family members give us a history that please help my wife, my mother. And knowing the metabolic aspect that can change the whole system of the patient. And we as dentists, we were all confined to the, the definition always said the systems innovated by trigeminal system. So that is what a dentist is supposed to know. But now we are becoming more of physician of a stomatogastric system, or system as a whole, the gut brain barrier, the the hypothalamic axis, and all that. Now these terms which were alien to us, me when I was 40, I was thinking of retiring, and now at 45, I'm thinking of joining in more and more courses and learning more and more, because the sky is the limit, and I know now that I know so little. And thank you,
Yeah.
ma'am, Dr. Savita, ma'am, Dr. Ramya, ma'am. Savita Dental College has always been pioneer in producing dentists and doctors who are changing the shape of dentistry. So thank you for being a part of this Congress. And on that note, I would like to welcome our next speaker for the day, Dr. Ruchika Sood. Dr. Ruchika, I know it is early in time, but can you just switch on your camera, ma'am?
It's on. Hi.
Hi, Dr. Ruchika. So, Dr. Ruchika goes, if you see her Facebook post, see, I'll tell you what, I've been given a very formal introduction of her. She's a founder and consultant at Neocare Orofacial Pain Relief Center in Mumbai. And this is just
Okay.
one sentence for her, but I would say more than that, just see her Facebook page and you will understand what is a true meaning of empathy, sympathy, and understanding pain, what truly it means. When I started learning or knowing about TMD or orofacial pain practice, there was only one name that came to me in India. That was Dr. Ruchika Sood, and she had just walked in from US, I guess, and then she was here. And please send all your cases there. That's what was the instruction, what we knew about. And so it's a privilege to have you as usual. I think this is also your third year with us, and you've been a part of our Congress always. So it's a pleasure to have you on board. Dr. Ruchika, as is the custom, the first is smile for the camera so that we have a lovely picture of yours.
Thank you.
Okay, thank you so much. And Dr. Ruchika, one thing I would like to know more. I mean, I'm asking all the speaker this question because this one mistake or habit that has changed or shaped your practice in a way that you've become a more diligent orofacial pain specialist or a pain specialist for that matter.
I think one habit is consistency and commitment to listening to my teachers. My mother very early on in life taught that राम जी जैसे गुरु वशिष्ठ की बात सुनो. And मेरे गुरु वशिष्ठ Dr. Gary Hare है. Dr. Hare has been Dr. Weldon Bell's student. And I think that has been one of the biggest blessings of my life, to be a student of Dr. Gary Hare and Dr. Eliav. So having that commitment and sincerity towards learning is, I think, one habit that really shaped me. And I loved hearing from you. I can resonate with the sentiments that 10 years, 15 years, 20 years, it only keeps increasing. The more you read, the more you know, oh my God, it's an ocean. We'll never reach to the patalok of this ever. And you want to deep dive more and more because then you feel like, oh my God, how many pearls are there? So yeah, that's one habit that I think is there. It's very essential requirement of being an orofacial pain specialist to commit to learning because it never stops.
Yeah, and as we know that your tea parties or evening tea party, the high tea parties that you used to host this year, I think you have not hosted any of us the
Or
tea
maybe I
parties.
hosted so many that there was no time for pictures.
Oh, that is what happened.
Yeah.
So please follow her page so you will know more about this tea party. It is nothing like a joke or secret because she keeps talking about a painful condition in a way that we understand that condition as a human being, how well we know our patients or how should we know our patients. The one person to go to is Dr. Ruchika Sood to understand the patient care much better. And Dr. Ruchika, one non-clinical skill that you need as a pain specialist that you would emphasize each and everybody of us to know?
Compassionate listening. You're a very good listener. To be a very, very good listener.
Yes, ma'am. And one more thing is, Dr. Ruchika, so rewind yourself 20 years from, just rewind back 20 years. One tip you would give to your younger self?
Don't worry, be happy. Every puzzle will find its piece, you know.
Yes, and your child will outgrow you mentally and physically and emotionally. You add to that also because you're a teenage child mother, so I know what you're going through right now. Okay. On that note, doctor, can you please start sharing your screen and begin your lecture?
Yes.
Dr.
Thank
Ruchika
you.
Dr. Ruchika is going to be speaking about in the invisible syndrome, complex orofacial pain in the modern pain clinic. Yes, your screen is visible, doctor. Can you start the presenter's mode?
Yes, we will. So thank you so much for having me. It's family. I still remember the first phone call that came from rural, and I was so excited. Something happening in orofacial pain, and I think we've grown a lot in last 3 years. So I'm already dreaming where we'll be at 1 decade. So thank you so much for having me. And this presentation, let me put my timer on for 25 minutes from now because this is a very long presentation. And this is chicken run. इसमें meat last में मिलेगा, शुरू में नहीं मिलेगा. Because I think we have varied audience. So I had to put the perspective into it first. Okay. Oh. So this presentation is all around helping you see everything in a complete picture. Why is it that orofacial pain is so complex? Because a lot of times we see it in pieces. And speaker before me, Dr. Ramya, put it beautifully. And I think a lot of success at NeoCare is because of the fact that we are into integrated care. where the metabolic dysfunction is very well understood by our team, and we address it. So to everyone attending and who has heard Dr. Ramya's talk today, I feel you guys are really lucky and blessed to get it on a platter, because it has been a journey of about 7 years of clinical practice for me to understand it and then figure out the formulas to treat patients. Because in real world, there are only two situations. Either you have helped the patient or you have not been able to help the patient. And this metabolic understanding is the key for understanding the crux of orofacial pain, or the hallmark of orofacial pain. We are going to go over this very fast, that why is it that it is so often misunderstood? Why is it, I'll take example of neocare, that sometimes we are the 40th doctor, we are 50th doctor, 17th doctor, and patients keep account. And every patient that I have seen would have met maximum number of dentists. They will say 6 dentists, 17 dentists, 3 pulmonologists, 2 neurologists. Why is it that so many dentists could not think orofacial pain at that point in time? So that is, I think, the work of all of us who are now more than 100 people in orofacial pain, and having our own academy in India today definitely facilitates the learning process. So orofacial pain symptoms are not consistent. They migrate. But that doesn't mean that patient psycho hai. That means we need to understand it better. Orofacial pain is an interdisciplinary or a multidisciplinary field where we have to approach it multi-pronged. There are no predictable patterns. Whatever we learn are our guidelines for orofacial pain. And we most often have to look very, very deep. There is a difference in pain management with orofacial pain, because this is the part of the body with a lot of autonomic nervous system. And that brings in a lot of difference in how patients perceive pain. So a pimple on face and a pimple on back are different for every human being. So we have to acknowledge it and treat accordingly. Why are they invisible? Why are these problems invisible? Because most of the times, by the time the patients reach our office, they are not even able to describe it properly. So we as providers need to have very, very sympathetic hearing for them, because their history is most of the times fragmented. And by the time they reach us, they also have cognitive deficits. So we got to be very, very patient with our patients. We need to read more, understand more on the face-brain matrix. And in the burden of busy clinic, a lot of emphasis is paid for imaging. And imaging has to support the clinical diagnosis, not the other way. And a lot of delay in the diagnosis leads to ambiguity or progress in the chronicity of the problems. Patient's narrative has to be related to the history and the clinical findings on the tests. This gap in correlations is what makes these problems or the syndromes invisible. A lot of times, there are no structural correlations. There will be high variability in the presentation, and the pattern can be waxing and waning. There could be overlap with a lot of symptoms. So understanding the pain mechanisms is the key. I was a blessed soul, because when I was at training in Rutgers, that is the time when Dr. Benoliel had joined Rutgers. So we had time and to spend with him and discuss at length about the pain mechanisms and the need of mechanisms-based diagnosis in pain. So yes, I've witnessed this shift. I have seen how the impact of treatment outcome is affected by bringing this shift. So please do pay a lot of attention to understand the mechanism of pain from patient's history, not relying on the diagnostic tests. That is where we are able to come to a point where we can help the patient. And yes, tea parties do help a lot in that. Have a cup of tea with your patient and they will be able to open up. Patients are very burdened with the image of a clinician and the social respect or status that they put. And in the process, hamara kaam kharab ho jata hai if we don't get the data. Only thing that we need to be careful about is the red flags. So all of these things work in the cases, the clinical cases, but not with the red flags. So what are these red flags that need immediate action or appropriate referral? Unexplained weight loss, fever, lot of systemic symptoms. And yes, this happens. Please do not underestimate the red flags in orofacial pain clinic. So many years of practice. And this story I'm going to share because very early on in my practice, Dr. Hare was very particular about the red flags, and being his student, we inherited it. So very early on in my practice, I had a patient of TMJ pain, which I also thought was a disc displacement. But this turned out to be a case of multiple myeloma. I think last year, Dr. Ajay had presented that case. That was a case of multiple myeloma. And the patient got diagnosed in time, got treated very well, and is here till date. And why I'm sharing this story is because after, I think, 10 or 12 years of being treated, he has a relapse now for last 6 months or something. Now, chemotherapy did not work when they did it again. So his days are limited. He still put in the effort and came to meet me and said, "Thank you for giving me those many years. You picked it up early and it gave me years to enjoy my grandchild." And see, as I'm talking, I'm still jittering. This is the power of orofacial pain because we are in the domain of human body where all emotions are, and we are all energy beings. So we connect with it. And there are many stories of red flags that I can share. This one was a good one. A bad one, which gave me sleepless nights early on in my practice. I'm not talking about today because today is okay. Pain is okay, is a part of my life today. But early on, where we really are excited about it, those days I saw a patient of leukemia. The patient was referred for unbearable gum pain. And that was his only complaint. And I could not figure out why there can be so much of gum pain, but there was unexplained weight loss. I sent the patient for investigations, and I suspected some form of cancer. I didn't know what it was, had done an appropriate referral. They were waiting for their tests and reports, biopsy reports, and the patient passed away in those 50, I think we took 15 days for all of this. I was still in the hospital setup then, and all of this took 15 days, but the patient did not see the 16th day. When there was biopsy report arriving, when the biopsy report arrived and the patient was no more, that taught me something. When you suspect a red flag, please explain it to the patient, the severity of it immediately. They should not lose time, especially in our country where health is very chalta hai attitude. And we as clinicians, when we see the red flags, we need to emphasize on it appropriately. So this subtle clinical cues we all see, we understand the diagnostic framework, but multidisciplinary approach is important, or interdisciplinary approach, as I call it. So what's the difference? The interdisciplinary is where all the clinicians sit on the table and discuss the case, and there is one treatment plan presented to the patient. Orofacial pain is done with biopsychosocial approach. So we understand the biology of the patient, integrate the psychology of that patient in the treatment plan, and understand what is the social status of those patients. Like this morning, one of the patients who can afford nothing, she can only go to a government hospital, and probably we are treating her here free of cost. But where do I refer her for whatever you want to refer her for? And because they've come to you from the government hospital, from this social strata is also a reality of our country and a very, very big part of it. We need to understand it and then integrate the care for the patients. Okay. The what you say, the burden of orofacial pain is fairly large. And that is why we need so many of us and working as a cohesive team. As a dentist, we need to develop an eye for seeing pain that gets generated beyond dental structures. The most common thing, I think, which I would really want to bring to the attention of dentists is how the patient is sitting in the dental chair. A lot of patients come complaining that this pain started after the dental procedure. And most of these patients, this is an observational thing I'm saying, have problems with their sternocleidomastoid muscle or some neck muscle because they sit in the dental chair with the neck extended in such a position. And sometimes that is enough for those pains to get triggered. But as a dentist, yes, making it a little more comfortable, supporting their neck maybe can prevent. So take the 2 minutes to ask the patient, do you have history of cervical spondylosis? Do you have any neck pain history or headache history? Because though patients who have pre-existing conditions may develop severe or more pain after dental procedure. Okay? There is a lot of overlap in the diagnosis with the orofacial pain problems. And I think one of the most common TMJ problems being diagnosed as toothache or ear pain, and neck pains being diagnosed as TMJ problems. With the use of phone, we have calcification of the ligaments happening in this part, and that is bringing in a lot of varied types of cervical pains, which are getting referred to the TMJ area. Okay. So yes, as a clinician, it's not easy, but we keep walking the path, using the tools which are available, like I think fairly advanced biomarkers that Dr. Ramya presented right before me. They are very, very useful. And Ayurveda addresses it beautifully, has been talking about it beautifully. And cancer being a metabolic disease is established. And we had many talks about it in US many years ago. So is chronic pain. Pain is only because of inflammation, and inflammation happens only because of gut issues, right? Trying to make it simple. But this was told way back in Ayurveda, which explains that all diseases happen for two reasons. What are those two reasons? Diminished Agni. So if your digestive system is poor. And second reason, if there is if there are toxins in the body. So we can keep breaking up and understanding the toxins at a molecular level, but how do we get them out of our body? I think Ayurveda works beautifully at a cellular level and gets them all out of our body. And homeopathy works very well with the vital forces. So yes, at NeoCare, we do have Ayurvedic doctors, we have homeopathic doctors, and it is integrated care for patients where they can get resolved. It needs patience, commitment, and consistency on part of patients. And there are people, about 20% of them, who just want injections and quick fixes. And for them, the cycle never breaks. And then there are a lot of surgical treatments that people are undertaking these days for temporomandibular joint problems. And I see there is a part of lecture on occlusal splints, so I'm going to skip this part completely and come to sleep. Sleep is an integral part of health. We're talking about inflammation, sustaining pain. Being sleep deprived is one of the most common reasons for pain being present in the body, because sleep deprived state is a state where there is inflammation which will stay. In Mumbai, when we are out at 12:30 in the night, 1 a.m. in which is, I don't know, night or morning, you can't make out. If I am on the road at 5 a.m., it's beautiful. No person seen there. But if I am out on the road at 1 a.m., it's traffic jam. So where are we going? We are energy beings running on the solar energy. So if we think we have grown bigger than nature, well, we have a lot of work ahead for us in the department of orofacial pain, because we are not nocturnal beings. So we have to integrate the sleep studies, understanding of the sleep of patterns of the patient very well in our management protocols. Another common thing is disc displacement without reduction being treated with surgeries, which is controversial. For disc disorders, non-surgical treatments are recommended. And post these surgeries, then we have different kind of problems that we are seeing in the patients. Okay. Yeah, we spoke about it. I'm going to go to the patients. We miscalculated the time, so that is why this presentation has been so long. But this is where I want to get to. Few cases which will help you understand the perspective better. Okay, 5 years of pain, 12 plus ENT doctors, surgery, imaging, medications, all of those things done. She was diagnosed with myalgia, pharyngitis, trigeminal neuralgia, TMJ disorders, glossopharyngeal neuralgia. One surgery done, stylectomy done. But when I saw this case, she's 22 mm opening, less than 25 mm. Very, very big functional limitation. Okay. And she has a suitcase full of investigations. And she has very, very bad neural sensitization. The first appointment with her was 3.5 hours. The second appointment with her was 1.5 to 2 hours. I'm saying it very, very loud for a reason, because these kind of cases do not get resolved with 15 minutes or half an hour of FaceTime with the patients. Okay. And we have to start treating these patients, understand the patterns, go back to the mechanisms, and then treat this patient. Now, what was her diagnosis? Her diagnosis was myofascial pain dysfunction syndrome, along with temporomandibular joint disorder. So, can I get her paper? Anu Agarwal. So what happens is, when we look, I want to get her paper because this is a fairly recent case, and this patient has suffered immensely, had all the means, had suffered immensely. What did we do for her? We did Ayurveda for her. We did homeopathy for her. We did physiotherapy for her. We did manual manipulations with her. I'm also trained in manual therapies and certain physiotherapy techniques, क्योंकि जिस जमाने में मैंने work पे start किया था, कोई नहीं था यहाँ पे. There was nothing. It was a compulsive need for me to do everything by myself. So we did the shift in her case started by release of the spasms in her spine. Shift in her case has happened with the release of spasms in the spine. So there is a lot happening in the facial region by the pathway connections between the spine and the jaw and the face. Read the patterns, diagnose the pathology, and label the patients. This is what I wanted to say. See in the paper where the shift had happened. So we need to identify the pain generators. This was her spinal spasm, which was the pain generator in her case. And it was really, really bad because the floor of the mouth muscles also were twisted. And that is why she was having excruciating pain. Muscles can play a lot of havoc, much more than we can think as clinicians. So never keep it out of the differential. Dr. Pertis, one of our teachers, used to talk a lot on this aspect. It is never invisible. We need to look with the right lens. This is the video of a 69-year-old female. She traveled all the way from a different country to find relief in the orofacial pain problem. You can see how her jaw is deviating. She could not talk. She could not eat because she cannot hold the bite. Okay, obviously, sare doctors and all those things, I won't again. The intensity of pain is not too high. The profile of the pain was located to the masseter muscle. Okay. But is it important that masseter has to be the generator of pain also? We know by now, no. And she had no other symptom. And the aggravating factor for this was talking and also chewing. She could not eat comfortably. But chewing this was not the problem of trigger points. This was the problem that she was not able to hold the bite. Is it a dystonia? Is it a dyskinesia? Every jaw movement is not about a movement disorder. This patient, again, was resolved by addressing the floor of the mouth muscles. She had done Botox in the past, which did not, because Botox was probably not done on the right muscle. Okay. But what had brought this kind of change in the muscles? It was death of her husband, which aggravated it more. And she also had losses in the family earlier to her husband's death. And the death had happened because of cancer. So there was a lot of suffering in it. What gives me the eye to see all of this is my training in palliative care. Palliative care is taught very well in our country. I did it at AIMS Delhi, and I really feel that it helps us a lot as clinicians to develop empathy and the eye to understand and communicate with these kind of patients. So her measurements are not bad. There were not major problems with her joint, but the problem, as I said, was with the floor of the mouth muscles, and Botox had already failed. So we worked with physiotherapy. And as it turned out, her son happened to be a physiotherapist. So once we brought her, okay, my time is up, but I'll just finish in 2-3 minutes. Once we brought her to a stable point, her son learned the home care. These were the things that were done for her treatment plan. And homeopathy was also used a lot. Why? Because the kind of trauma that she went through and had disturbed her vital force, homeopathy helps a lot and very well to deal with the emotions of the patients. They don't have psychological problems. The body is keeping the score in these kind of patients. And how do you bring it out? Talk therapy is not something that is meant for everyone. What is meant is maybe Gestalt, which is going to bring out the problems to their awareness and then use good alternative techniques. This is how she left, talking, smiling, and eating right. Okay. And so jaw deviation can be a functional problem also, not always structural problems. And no amount of imaging will help us understand these kind of problems because the muscles have to be understood. Okay. And I have still more cases, but I think we'll stop here because our time is up. I don't want to screw we have 3 more cases. Dr. Son.
Doctor, you have 4 minutes more. You can speak for 4 minutes more.
Speak for 4 more minutes? Okay. So we will see that diagnostic. 94, sorry. So please listen to this video. I really wanted to play this case because with the video, this is fair dentist, fair patient, real honest communication, where the dentist has explained to the patient, I do not know why you are getting this pain in this tooth. There is no periapical pathology, but we can try to do a root canal and see if it helps. We don't kill a person to see if the person can live. That is what we do. If we don't find a periapical pathology, root canal is not the treatment modality. Please, this is the message that I want to communicate by sharing this case.
So when the pain started, initially I thought it is related to teeth problem. So I approached to my dentist, nearby dentist. So she also told that she is not able to find anything in the X-rays. But then still I insisted that there is some problem is going on. Because one or two sittings, she told me that nothing is there, so please go home. There is no treatment for this. So she is also not able to understand from where the pain is coming. But then still it is unbearable. So then I requested her to go for a root canal. So that is how I have done the root canal for 2 teeth. But still there is no respite. And then somehow I started searching what can be the other reason for this type of a problem. So fortunately I could see that get some reference from the internet that there is some physiotherapy is there for the PMJ pain. Somehow I don't know from where it has come to me, but I could get a reference from the internet that there is one madam, Sud madam, in Washi. So she is having a very good amount of exposure and experience, and that is how I could get from the internet. And when I approached the madam, I visited the clinic at Washi, and fortunately, whatever the ways she approached the problem. So I'm really happy to share that if I rate the pain 0 to 10, 10 being the highest pain. So now I am at the level of maybe 3 to 4. Thanks to madam for the methodical way of approaching the problem.
So we don't need to hear the testimonial part of it, but the pain part of it was very, very important and significant for me to share. That root canal is not a treatment of trial and error, because now we have denervated a healthy tooth. And please think TMJ, please think myofascial pain syndrome, please think metabolic disorders. If you cannot find a pathology on the X-ray before picking up that burr to drill, okay? And this is the true clinical algorithm. Please listen to the patient, rule out red flags, run the minimal required diagnostic exams based on the patient's history, stabilize what's unstable in the patient. By this, I mean, like in this patient, it was arthritis of the joint. Make him a stable splint, stabilize the joint, then you can deal the trigger points of the masseter muscle, which were referring pain there, and temporalis muscle, which were referring pain. And then look for more. There can be more always in every particular case. Okay. And once the function is normalized, that's when we look for behaviors. Is there anything in the behavior of the patient which is contributing to these problems? So I think
Yeah, Dr.
this is my experience of so many years that I tried to share and see if it helps my field, my domain. And for anyone who is in love with orofacial pain and wants to deal with it with the depth of madness, you're most welcome for a cup of tea at Neocare. Every Wednesday is my academic day. I'm sitting with some of the other colleague from some fraternity who wants to deep dive into the world of pain.
Thank you, Dr. Ruchika. And as always, it's a pleasure learning from you. And one take-home message, I think, from your tea parties is before adjusting treatment, adjust our understanding of the patients. So thank you so much, Dr. Ruchika. And on that note, I would like to welcome our next speaker. Yeah, our next speaker is Dr. Divya Dilip Kumar. It is our great pleasure to introduce her to this forum. I think this is her second year in a row to be a part of International Orofacial Pain Congress. Dr. Divya Dilip Kumar, are you there? Yeah,
Yes,
Dr.
yes.
Ruchika. Yeah, Dr. Ruchika, she'll stop sharing her screen, then we can start with you.
Sorry, I think.
Yeah.
Close window. Yeah, found it.
Thank
Sorry
you.
about that. It took me a while to find the window to close.
Thank you so much, Dr. Ruchika. It's always a pleasure listening to you. And beautiful shawl you're wearing there. Thank you.
So that's a dupatta from Thane.
Oh, Thane. Okay, Thane. Thank you. Thank you. Okay, ma'am.
Bye-bye.
Always a pleasure listening to you. On that note, let's bring in our next speaker, Dr. Divya Dilip Kumar. Dr. Divya, say hello to the screen.
Hello.
Hi, Dr. Divya. Smile for the screen. Okay. Dr. Divya Dilip Kumar is a renowned orthodontist and accomplished orofacial pain specialist, founder of Dr. Divya Dilip Kumar Orofacial Pain Center. I always miss this Dilip and Divya together. They are the husband-wife duo who are doing extremely well in the field of orofacial pain practice. And one must learn. She's given me, she gave me a good, I think 200 words history bio for her. But I would put it in my words is one thing that you need to learn from Dr. Divya is how to manage clinical practice and as well as how to create a social awareness through social media. Like, this awareness for the field, thanks to her, many of my patients come and ask me, are you Dr. Divya's friend on Facebook or on Instagram? So imagine that kind of a social presence if somebody has created not only for herself, but for the orofacial pain practice as such. This is commendable, madam, and hats off to your dedication and your team and the people who are behind it and your husband also. I will not go into the details of whatever you sent me because you are a master's in orofacial pain practice and then sleep medicine practice from Roseman University. You're Dr. Davis Thomas's favorite student. You are a mentor and all that. Everybody knows about you. But one thing I would always emphasize about somebody who actually made a change in orofacial pain practice to become a social cause is Dr. Divya Dilip Kumar, and congratulations on that. You and your husband are creating phenomenal videos and your team is phenomenal in doing so, and something that you should be actually teaching people like us who don't, I mean, a person like me, if my laptop goes into that browsing mode, I change my laptop. That is the understanding I have for tech. I'm that tech savvy. So imagine this. So please have more courses for how to become socially present or create your social page and everything, whatever you do. So on that note, Dr. Divya, I would like to know, since you have grown into your practice one step at a time, there must be some mistakes and some habits that you inculcated in your practice that has shaped this practice to this. So can you elaborate on one of that habit or mistake of yours?
In orofacial pain, you mean, doctor? Or
anything. Orofacial pain, this is the Congress for orofacial pain. So,
So in orofacial pain, mistakes that I have done is, as always, as like everyone do, extraction of molars, giving stents. I've been there, done that. But now
misdiagnosis.
Yes.
So you're humble enough to accept it that you have been through the path like all of us.
We didn't know. Then we didn't know what to do. So all that we could do is try taking try doing molar extractions. Then try splints. But that thing has ever worked.
And I'm sure you're still married to that patient.
Yes, that's it. And so then patients go from us to next dentist, and then they don't have relief at all. So
Yeah.
that's how it was always been. But now when I look back and see those cases, now I've actually called back those patients who we have done re-root canal, extracted and put implants. Now when we call back those patients and check, then it is the muscle. The patients still have pains, and still they've been waiting
They
for
have
the
been
pain.
treated. Yes.
So
So humble of you to accept that this is what we do, and this is the forum. This whole theme for the Congress is what not to do.
yes.
So on that note, please welcome to International Orofacial Pain Congress, and you may start sharing your screen, Doctor. Dr. Divya is going to be talking about something which is very, very dear to her: trigger point injections. That too, ultrasound guided trigger point injection, a revolution in pain management.
Yes, are you able to see my screen, Doctor?
Yes, doctor. Yeah, you can go on a presenter's mode. This is the presenter's mode. Yeah, go ahead, doctor.
Is it okay? Am I visible?
Yes, please go ahead.
Okay. So my present topic is on ultrasound guided trigger point injections. So first, I would like to thank Dr. Sonal for giving me this opportunity year on year. Last year, also I spoke in the International Orofacial Pain Congress. Thanks for giving me an opportunity. Ever grateful for Dr. Sonal for being so encouraging and putting on this platform. And so my presentation was supposed to be on 21st. So it's actually preponed. So now what do we know about all this? So you've been today, the topics were on myofascial pains, orofacial pain, and the trigger points. So now what do we know about what are trigger points? What are these? How are these formed? And what is actually happening to our body? So first things like Dr. Ruchika Sood, before me, she spoke beautifully on how these trigger points are formed. So these trigger points are generally because of emotional stress factor that actually tightens the fascia. So this fascia tightness, what happens is the muscles go into a mode of tightness, and there are small knots that are formed in these muscles, and these are called as trigger points. Now, when we release these trigger points, we see that this fascia gets relieved. The fascia that is becoming tight and causing all these pains of temporomandibular joint pains, the neck pains, shoulder pains, sometimes giddiness, tinnitus, all this are because of the fascia stuck in that mode. And when we release this fascia, slowly all this gets relieved. So now how do we do that is generally we do it using trigger point injections. The other modalities are physiotherapy, posture correction techniques, cognitive behavioral therapies, and then stress management protocols. So this trigger point injections are given using lignocaine, 2% lignocaine, and exactly onto the spot of the triggers. And when we feel the triggers, the trigger actually breaks and there's a twitch that is formed. And then in that we inject 0.2 ml to brush away the trigger. Now this can be done. So going back to what is trigger point. So trigger point is a hyper-irritable knot or nodule in a taut band of muscle fibers that when pressed and causes local tenderness. So there's also a twitch response when we actually release the triggers. So this is done. See, these are the general trigger points that we see. And the trigger point is just under, and it's in the muscle and under the fascia. So when we release the trigger point using trigger point injections, these knots are broken. So what I have seen practically is these knots have several layers, and it is not just one trigger point, one trigger layer that is broken. There are several trigger layers that are there. And as we keep breaking, the new triggers form, and then we have to break all that. So this can be done in superficial muscles. Superficial muscles in the sense the trapezius, masseter, temporalis, all these are superficial muscles. So there we can directly give trigger point injections, manual trigger point injections. Now, what happens if the trigger points are there in deeper muscles like the lateral pterygoid or the anterior digastric muscles, and some specific structures like the carotid artery that is nearby in the SCM muscle. So in these places where trigger point injections, giving direct trigger point injections is a little tricky and it's a little risky, then that is when we take up this ultrasound guided injections. So what is ultrasound guided trigger point injections? Now, ultrasound is a real-time imaging to precisely guide a needle into the knots. So thereby we bypass all the major major vessels that are there inside the muscle. So that is what happens in our lateral pterygoid muscle. Lateral pterygoid muscle being a very small muscle. we will have to bypass all the arteries, nerves there, and the vessels majorly. It's all very closely linked because it's a very small muscle. So we have to be very precise in injecting the muscle. So this is where the ultrasound technique actually helps. So this is one of the patients where we have given the lateral pterygoid ultrasound guided injection. Sorry, that's a mistake. So this is a lateral pterygoid ultrasound guided injections. So here what happens is the probe, this is the probe where we look at the ultrasound of the lateral pterygoid muscle is seen. So how do we actually see it? The one who is doing it is the radiologist. He's a musculoskeletal radiologist. So we do these techniques along with a radiologist who is specialized in ultrasound guided musculoskeletal ultrasound guided injections. So he actually guides us to where the tip of the needle should be. So he places the probe of the ultrasound machine onto the lateral pterygoid muscle. Ask the patient to open and close the mouth. So as the patient opens and closes the mouth, the lateral pterygoid moves a little. So then he identifies where the lateral pterygoid muscle is. After that, I inject exactly in the middle of the probe. So as we inject, we put around 2.5 centimeters into the, so 2.5 millimeters into the 25 millimeters or 2.5 centimeters depth. So generally it is between 1.5 centimeter to 2.5 centimeters. That is the depth into where the lateral pterygoid muscle is. So we inject and then aspirate to see if there's any other vessel there nearby. And then we inject. Now, as we inject, we will be able to see. Now, this is how we inject in the lateral pterygoid muscle, and we'll be able to see exactly where the needle is, the tip of the needle is, where exactly the liquid, that is lignocaine, is going into. All that will be clearly visible in the ultrasound. But we will not be able to get the twitch response that we usually get while we do manually, directly when we do, because the other muscles are big, we get the twitch response. But here we generally do not get the twitch response because the muscle we are targeting is very small. Now this is another case where we give the ultrasound guided injection for a sternocleidomastoid muscle. But generally in our clinical practice, this is given directly. It is given without the ultrasound because it is easier. Here we have actually published. We are publishing this ultrasound guided trigger point injections. So for that we have done all the muscles under ultrasound guided injections. So here this is the sternocleidomastoid muscle where we inject through the bulk of the muscle and we bypass the major structures like the carotid artery and internal jugular vein. Now this was during a course that we conducted of the ultrasound guided injections. Here we did ultrasound guided injections for all the muscles like the SCM, trapezius, and the masseter. So this is for the trapezius muscle. Here we are giving trigger point injections, and actually trapezius is very easy to inject. That is, we hold the bulk of the muscle and then we inject directly. So, and here again, this probe was used because we wanted to show it, we wanted to publish it. So we use this. But one disadvantage, one major complication in the trapezius muscle when we give the trigger point injection is when the probe is directed downwards, it might hit the lobe of the lung. So that is one danger in giving trapezius ultrasound trapezius injections, and we will have to be really careful with the direction of the injection that we give in the trapezius muscle. Now this is for the anterior digastric muscle. So when do we give? First of all, when do we give anterior digastric injection? Is sometimes when the patient has anterior digastric muscle spasm or tightness or triggers there, patient feels his pains in the lower anteriors, a pull in the lower anteriors. So this is when we identify that the trigger points are in the anterior digastric. So here again, anterior digastric, the probe is placed on the anterior digastric and the thickness is that is only 1 centimeter of the needle is injected, put inside and then aspirated and then injected again. So 0.2 ml to 0.5 ml is the maximum we inject for each trigger points. Now this is a closer picture of how we do the anterior digastric muscle. So is ultrasound guided technique effective in the diagnosis of triggers? So this is how you see the red and the blue you see are the deposition of the liquid after we deposit. And then the vessels are seen. So this can be changed. The colors we can change the colors to see For example, if we need to see the trigger liquids more, then the radiologist actually changes the contrast and sees it. So what you see here is the ultrasound, lateral pterygoid muscle, the anterior superior head and the inferior head of the lateral pterygoid muscle. Now this is the post-injection. This is after injection. You see, this is where the liquid is deposited. So now, talking about ultrasound guided injections in detail, is it really a necessary technique? If going in for deeper muscles, definitely yes. We cannot just like that blindly do injections in lateral pterygoid muscle, and never do lateral pterygoid injections without an ultrasound, because even with the ultrasound, we find it very difficult to actually exactly insert it into the lateral pterygoid. And when we insert into the lateral pterygoid also, there are so many instances where we have punctured the artery. So we have to be really careful while injecting the lateral pterygoid. So be very, very careful. A good musculoskeletal radiologist who is actually trained in this technique is very important, because only then they will guide us into the lateral pterygoid muscle. And why do we actually need to give lateral pterygoid muscle trigger point injection is, one, when the patient has pains around the ear region. Another one, what we have seen is in disc displacement types. So what happens? The disc gets displaced forwards. When it gets displaced, the displacement might be most commonly because of the lateral pterygoid that is actually pulling the disc forward. So lateral pterygoid is attached to the anterior portion of the disc, and when this lateral pterygoid is tight, the disc actually moves forward. So in cases of disc displacement, we have found amazing results when we give trigger point injections to this lateral pterygoid muscle. So when we give trigger points to lateral pterygoid exactly under the guidance of ultrasound, we see that the lateral pterygoid actually relaxes and the displacement gets corrected. So amazing results we have seen with lateral pterygoid, ultrasound guided lateral pterygoid injections. And again, the technique is very, very important. It is very technique sensitive. Technique is very important, and always bilateral has to be given. Even if the patient has pains on one side, it is recommended that we give bilaterally, because the other lateral pterygoid might be tight, but we might not know if there are triggers or not. So it is always better to give trigger point injections on both sides of the lateral pterygoid muscle. Coming on to the anterior digastric, again, that is also very, very tricky. Anterior digastric muscle. Most patients, if you see, when all the other muscles are relieved, they still complain of the lower anterior pain. So lower anterior pain is definitely a referral pain from the anterior digastric. And again, there are a lot of structures here in the anterior digastric. We cannot take chances by just like that directly giving injections. So again, here the ultrasound guided injections plays a role. And for some patients, when you feel the sternocleidomastoid is very thin, in these patients also, not to take a risk, we actually give ultrasound guided trigger point injections. And like I told you, in all the other muscles directly, masseter, we are very sure we know how the structures are. So in masseter temporalis, we can directly give, because anyways we'll be hitting the bone. So when there's a bone, then you can be you are rest assured that you're safe, that you don't hit any other structure. So when a bone is there, then you can directly give the trigger point injections. So remember this: when you have an underlying bone, the trigger point injections that we are giving is mostly safe. So when you don't have some structure to support, then you cannot blindly give those injections. That time, ultrasound guided injections helps a lot. So I would like to tell that I did my fellowship from Rosemont University under Smile USA with Dr. Davis Thomas, and actually we conducted a course on this ultrasound guided injections. So this was a course that we conducted last year, and yes, this year also we are trying to conduct a course on ultrasound guided injections. So people who are trained in trigger point injections, you can explore further by giving these trigger point injections, because like I told you, we cannot take risks in few cases. So in those, we cannot take risk in few cases. So in those cases, especially in cases where there is disc displacements, just by giving a splint, we have seen that the disc does not go back at all. So when you give this lateral pterygoid injection, definitely the disc loosens, and like I told you before, we have seen amazing results of the disc going back. So if you are, for those who are practicing these trigger point injections, I would suggest go on to doing ultrasound guided trigger point injections. Find out a musculoskeletal radiologist who can guide you in doing this. So once you try doing this and see the relief that the patient has, nothing like that. So now this is when I did my master's in orofacial pain. This is my establishment, Dr. Divya Kumar Orofacial Pain Center. And thanks to you all for giving me this opportunity, and thanks for the patient listening. Any help you all want regarding trigger point injections or regarding these doubts in orofacial pains. So I see volume of patients now. I know how differently patients react actually. So trigger point injections are not just what we have seen in the textbook. It is like when we give a trigger point injection, there are so many other things that are happening that are not even actually written in any of the textbooks. A lot of things that we see, a lot of different symptoms that are cropping up, a lot of other muscles getting tightened when we give trigger points in one muscle. There are a lot of things happening. So there's a whole, I think, still there's a whole lot of science that has to be under this trigger point. I mean, so much of what mystery behind these trigger point injections that has to be solved. So any doubts on this or any help you all want in the trigger point injections or about ultrasound guided trigger point injections, I'll be very happy to help you all. You can take my mail ID and you can message me anytime. So what I always feel is the mind does not know, the eye does not see. What the mind does not know, the eye does not see. And the eye sees what the mind knows. So when you see a case, if you know and if you are able to identify what it is, then we'll be able to diagnose it right. But if we do not know what the subject is, if we do not know that there's a new specialty like this, there are so many things happening because of these triggers, then we blindly do other techniques. So we go wrong by the wrong diagnosis. So this is a whole new subject, and Dr. Sonal is doing an amazing job of putting all the speakers together in this International Orofacial Pain Congress. And this is a new specialty where each of us need to know what this is, because every day in and day out, we have so many patients with teeth pains, which are not actually teeth pains, with pains in the eyes, pains in the ears, pains radiating in other places, which are not from actually that place. So this is a huge specialty which needs awareness. And I would urge every one of you to actually learn this specialty, take this as an opportunity to know more about this specialty. Thank you, Dr. Sonal. I think I was
Thank you, Dr. Divya. Yeah, you are well under your time, and thank you for accommodating. Actually, Dr. Divya's lecture was to happen on Sunday, but then Dr. Tara was under weather, and that is the reason we requested Dr. Divya to fill in space for her, and Dr. Dipti will be the next speaker. Dr. Divya, thank you so much, and more than emphasizing about everything and what we have learned over these years, that none of the patients follow textbook, and no two patients having same diagnosis will respond to the similar treatment plan. So thank you, Dr. Divya, to bringing in this multifactorial pain presentation with a treatment plan that many of us have heard of. We are practicing as orofacial pain specialist, but a different angle to it, wherein we are doing it in a very systematic way. And thank you for emphasizing that we need to have a specialty radiology with us who will guide us in with ultrasound care, so that we can help patients who have such tricky, painful trigger points, that we can inject and help the patients with proper pain care. Dr. Divya, there are many questions in the chat box, and there's one question which I also want to know from you, is that is there any book that you refer which is a non-medical book that you always go back to or look forward towards reading again, or that has shaped you to the person you are today?
non-medical. Sorry,
Yeah, non-medical.
Okay, I follow Robin Sharma. So the
Okay.
5 a.m. club, Who Will Cry When You Die. So I'm an ardent fan of him. So much to learn from him. So I follow his books.
Oh, great. That's a lovely set of inspirational books he's already given us to read to. Thank you, Dr. Divya, and it's always a pleasure listening to you. I would like to have one full complete session about social media marketing from you and your team, and keep doing the good work that you are doing. And I'm very fortunate to have speakers who just, I have to just make a phone call and they are there for me. They're like, okay, Sonal, tell us the date when you want me to speak. I'm ready with the content. And Dr. Divya, Dr. Ruchika, Dr. Ramya, the ones who are always there. So thank you so much. Thanks for bringing in orofacial pain specialty to each and every dental clinic now. So with this congress, I hope many of the dental dentists who are budding dentists or seasoned clinician, they would also want to start looking into patients with a clinical symptom which is non-odontogenic, and they want to think laterally. So thank you so much, all of you. And yeah, you were saying something.
Yeah, no, these answers, how do I answer? Maybe
In the chat box. In the chat box, you can visit the chat box. There is something like
now,
chat. Later, you'll have to type into the chat box, because as I said, that there are many, and then you can personally interact with them. You can drop in your email ID also, and
I'm just putting my email ID. Anyone who wants to,
yes,
any questions, please do put in the questions. I will definitely answer.
yes. So as me and Dr. Divya were discussing, that pain is personal. The nervous system remembers stories.
Exactly.
And it's never a textbook record. Like, you cannot say that one patient formula, one size fit all formula works for orofacial pain practice. Thank you, Dr. Divya. And on that note, I would like to invite our next speaker, Dr. Dipti Bhatnagar. Dr. Dipti Bhatnagar is also filling in space for Dr. Tara. And thank you so much, dear Dr. Divya and Dr. Dipti, for filling in this space. Tara is under the weather, so she cannot join us today, but maybe tomorrow or day after she will join us. Dr. Dipti Bhatnagar, can you say hello to us?
Hey, hello.
Hello. Yeah.
Hello all.
So smile for the camera, as is the ritual. Yes, thank you, ma'am. Thank you so much. Dr. Dipti Bhatnagar is also a part of our Orofacial Pain Congress since, I think, this is also your third year with us. Yeah. So she is also Dr. Davis Thomas's student, and you've completed your master's also, I guess. She's a consultant oral physician from Bhatnagar's orthodontic and dental surgeon at Chandigarh. And Dr. Dipti is going to be talking about diagnostic challenges in burning mouth syndrome. So syndrome, symptoms, whatever you call it, doctor.
Yeah.
I know the
Disorders.
it's a
So many
misnomer. There are
terminologies.
so many terminologies, and it as we are evolving, this term is also evolving.
Evolving,
There are so
yes.
many things. But before we begin, doctor, there is one mandatory question, one compulsory intrusion into your personal life. That is what I'm doing. So one mistake or one habit that has shaped you to be the pain physician today. So what would you narrate that story to?
I believe a habit. I can say it as a habit. I always have a habit of talking to the patients. So
Correct.
taking a history, talking to the patient, most of the times the patient gives us the diagnosis.
Oh, great. And one non-clinical skill that you think as a pain physician or as a physician or a dentist, you would say that every dentist should have?
I feel being empathetic to the patient,
Okay.
showing empathy towards the patient. Yeah.
Thank you so much, Dr. Divya. And it's always a pleasure listening to you. One thing I would always want to learn from you is to be so humble, so soft spoken. I am a loud person. My husband always say you have made me partially deaf because you're yelling continuously into my
No,
ears.
but that suits you, Dr. Sun.
Thank you so much. I'll tell that to my husband that I got a compliment on that also.
It's not yelling, it's you can say it's your aura.
Okay, thank you. It's an aura. Thank you so much, ma'am. And can you start sharing your screen here?
One minute.
Yes, please go ahead. Is this share screen button, the green button down?
Yeah, that is there, but I am not able to see my screen.
We were talking about trigger point injection. Dr. Divya was mentioning about lidocaine, lignocaine 2%, but I would say the most important analgesic that a dentist or a pain specialist can have is validating that patient is in pain. Validation is most important. Empathy towards pain management starts with the dentist acknowledging that patient is in pain.
Yes.
Yes, Dr. Dr. Dipti, your screen is visible. You can go on presenters mode.
Yes.
Yes.
So, good evening, all. I would start with thanking Ipcon and Dr. Sonal for giving me this opportunity to speak in front of all. And also would like to thank my mentor, Dr. Davis Thomas, because of who we are here today and talking on in pain conference. Uh, so my topic for today is diagnostic challenges in burning mouth syndrome. It's also there are various terminologies given for burning mouth syndrome. I'll start off with, as per according to the International Headache Society in 2018, burning mouth syndrome, they defined it as an intraoral burning or dysesthetic sensation recurring daily for more than 2 hours per day over or and for more than 3 months without clinically evident causative lesions. Likewise, the International Association for the Study of Pain, they define BMS as a chronic oral mucosal pain or discomfort that has no identifiable causative lesions and is not caused by any other condition or disease. In both the definitions, burning mouth syndrome is to date considered a painful cranial neuropathic condition and therefore a direct consequence of injury or disease affecting the somatosensory system. So that was discussed in International Association for the Study of Pain in 2020. Despite these differences, particularly in the descriptions of the symptoms, the emphasis in both the IHS and IASP definitions relies on the lack of visible intraoral abnormalities and the absence of causative disorders that may explain the burning sensation. As we know, their patients, they come up with a common complaint of burning. So burning, we have to first, burning can be because of many factors. It can be because of something present, some lesions in the mouth, or it can be a dysesthetic condition, or it can be a burning mouth syndrome. So several synonyms for BMS were suggested in the past as patients experience different symptoms, not only burning sensation. And the various terminologies were given like stomatodemia, stomatopirosis, glossopyrosis, oral dysesthesia, sore tongue, glossopyrosis. All these terminologies have been given, but burning mouth disorder was further given, burning mouth syndrome was further given this name. It has recently been proposed that it's not a syndrome, it's a disorder, and which highlights the patients who have an abnormal physical condition but do not always display a consistent set of clinical features. If we talk of BMS, burning mouth syndrome, if we talk of the prevalence rate, it ranges from 1 to 40%, which is it's highly variable and is predominantly found in women, most commonly post menopause, rarely seen in younger individuals, and 50% of these patients, they show partial improvement within 6 to 7 years. But if the patient, they do not take any treatment for this, so there is hardly any spontaneous, you can say, remission which takes place. So in general, 1.73%, the prevalence rate in clinical, 7.72 in a. So in various countries, it's been, the prevalence rate has been given like that. The age of onset ranges between 5 to 7th decade of life, more commonly present over 40 to 50 years of age, and seen most commonly in females. So if we talk of burning mouth syndrome, it is primary, it is secondary. So primary, based on the causes of the burning mouth syndrome, it is secondary in nature. So if we talk of the causes of burning mouth syndrome, there are certain medications which result in burning in the mouth. There are certain antibiotics, thiazide diuretics, antiretrovirals, AC inhibitors, hexidine mouthwashes, antihistamines, cinnamon containing toothpaste, drugs which lead to xerostomy or dry mouth, like many antihistaminics, drugs which cause taste disturbances. All these patients, if all these drugs also result in burning in the mouth. So we have to rule out what is the exact cause by taking a proper case history. Secondly, one factor is drugs. The second factor is the medical history. So, if the patient is suffering from diabetes or gastroesophageal reflux disease, thyroid, hyper, patient is anemic, menopause or perimenopausal stage, dry eyes, dry mouth, Sjogren's, certain autoimmune disorders like SLE, scleroderma, ear infections, upper respiratory tract infections, alcohol, people who are on alcohols, who are chronic smokers, people who are undergoing radiotherapy, chemotherapy, etc., etc. So all these patients, they will come up with a complaint of burning in the mouth. So these are the local factors. Coming to the systemic factors, I already discussed deficiencies, immunological mediated disease, yes, psychogenic disorders. So that also has a very major role to play in burning mouth syndrome. Psychosocial stress, some stressful life event which much must have occurred in the life, endocrinal disorders. So there are certain investigations which is a protocol we follow if a person comes with a complaint, simple chief complaint of burning in the mouth. So this is the list: CBC, all the vitamins, iron, ferritin, serum ferritin, zinc, HbA1c for diabetes, thyroid, TFT, LFT, ESR, CRP to rule out any inflammatory disorder in the body, autoantibodies to rule out autoimmune disorders, serum homocysteine level, and candidiasis, taking a swab or a smear from the oral mucosa. So, what is the diagnostic criteria which is given by the Headache Society, and in 2020 it was published in Cephalgia. So, the diagnostic criteria is oral pain fulfilling criteria B and C, that is recurring daily for greater than 2 hours per day for greater than 3 months, and the pain should have the following characteristics: it should have a burning quality and it should be felt superficially in the oral mucosa. D, oral mucosa it looks totally normal, and the local and the systemic causes have been excluded. And E, not better accounted for by another ICOP or ICHT criteria. So, coming to the pathophysiology of the burning mouth syndrome, which is a bit boring, but then at the same time, it is very important also. So, if we talk of pathophysiology, it has three components basically. The exact etiopathogenesis of burning mouth syndrome is not known, but then there are three components. One is your neuropathic component. Um, it is considered as a neuropathic pain disorder. There are certain neuropathic mechanisms which involve loss of function in the somatosensory or pain and the taste modalities, manifesting in the form of some negative signs and symptoms and some positive signs and symptoms, as well as decreased top down central inhibition. So, if we talk of negative sensory signs, they are like absent sensation or paresthesia or diminished sensation or loss of taste or dysgeusia, we say. Whereas positive symptoms include pricking, tingling, burning. So, peripheral and the central neuropathic abnormalities can be involved in burning mouth syndrome patients at different levels. And they can include damage to the peripheral small fibers, damage to the trigeminal system at the periphery or at the brainstem, or signs of decreased inhibition within the central nervous system. So it's a common clinical phenotype which affects the peripheral system and the central nervous system. as I discussed, negative sensory systems and sign in quantitative sensory testing, which is implicated clinically as loss of function in the QST of cool, warm, and heat pain detection, neurophysiological signs like abnormal habituation of the blink reflex, dysgeusia, elevated taste detection threshold, or loss of function of taste difference. So people will have metallic taste, or people will have loss of taste. So they won't be able to differentiate, they won't be able to appreciate normal food, or everything will taste, you can say, metallic, or it will be abnormal. They won't enjoy eating food. uh, there's also a depletion of dopamine in the basal ganglia, which is because of the disinhibition within the endogenous top-down inhibitory dopamine opioid pathway. Hormonal imbalance at menopausal, so endocrinal component is also there. Hormonal imbalance at the menopause, together along with anxiety or stress, because there is loss of neuroprotective steroid production in the body. Environmental exposure to neurotoxic agents resulting in small fiber neuropathy and nigrostriatal dopamine system disorder, decrease in functional MRI activation. So reduction in the endocrinological component, first was neuropathic, the second is endocrinological component, resulting in reduction in the tongue epithelial thickness and the loss of keratinization, minor salivary glands hypofunction, resulting in xerostomia, oral dryness, preclinical inflammation, burning pain, and uh, the general dryness in the mouth. Then you have a psychological component. Uh, any stressful event which has occurred, the psychological distress which suppress the hypothalamus pituitary axis, lowering the gonadal hormone levels, psychological distress related to failure to alleviate the symptoms, alterations in the neuroprotective steroids like progesterone, which affects the GABA receptor modulation, leading to mood changes. So all this is you can say, a pathophysiology or the etiopathogenesis, which results in burning mouth syndrome. Coming to the clinical presentation, how the patient comes up with, normally people who have BMS, they have burning present all over the mouth. It is bilateral, multiple sites may get involved, but the most common or the most frequent sites which are affected are the interior two-thirds of the tongue. Most commonly, the patients will come up with the burning on the tip of the tongue, or burning on the dorsum of the tongue, lateral borders of the tongue, anterior hard palate, labial mucosa, and the lower lip. So these are the sites which are commonly affected. And if you talk of the intensity of the burning, it ranges between, like, you can say mild to moderate, 6, or you can say 6 to 8, or 5 to 6, or 5 to 7. So mild to moderate intensity, it's not as severe. There may be some comorbidities associated with burning mouth. Patient will also complain of dryness in the mouth, although sometimes there may be no dryness, but the patient experiences it. There is an altered taste and altered smell. And most commonly, patients will say they are absolutely, you can say, normal when they get up in the morning, but then as the day progresses, the burning worsens and it is worse in the evening. There's a lot of stress, vulvodynia, and other associated pains are also there. Yes, the burning, what aggravates it? Eating spicy foods, acidic foods, alcohol, that aggravates the burning. What relieves it? How the patient finds, feels better when they take, you can say, whenever they take cold foods, even if they take ice cream, they feel better. So anything cold, drinking, eating cold beverages, sucking lozenges, they feel better. Dysgeusia, as I already discussed, bitter metallic taste is seen in 50 to 70% of the patients. So, what are the, you can say, the characteristics of the complaint? Like, what terminologies the patient give when they come up with these kind of burning is, of course, there. It is painful, it is burning, it is tender, it is raw, it is tingling, it is hot. I feel it is little numb. I feel there is some raw area. I feel some discomfort. It's annoying kind of pain. So these are the descriptors which are given by the patient who comes up with this problem. How it started? Yes, there may be some history of some illness which had occurred, a viral illness or a bacterial or a fungal, anything. Respiratory tract infections. Yes, dental treatment. I took dental treatment. After that, it started. Some medications patient was on, or some certain traumatic life events which had occurred and which changed the life of the patient. So we already spoke about the negative symptoms and the positive symptoms. Yeah, the comorbidities like headaches, they may be associated with these headaches or TMDs or atypical facial pain, TN. So these are the comorbidities. May not be there with the patient who has a BMS, but then these all are the comorbidities with burning mouth syndrome. Yes, the most commonest is psychiatric, like the anxiety. Most of these patients, 80% of these patients, they have anxiety and depression. They have sleep disturbances. They have either problem going to sleep or they have problem maintaining the sleep. 24% of the Parkinson's disease patients, they also have these symptoms: thyroid dysfunction, extraoral pain symptoms like fibromyalgia and TMD. So sleep disturbances increases the risk of BMS. It's vice versa. BMS affecting the sleep, or sleep disturbances increasing the risk of BMS. BMS patients report a circadian rhythm of pain, but no influence was found using melatonin to reduce the BMS symptoms. Anxiety and depression, patients often suffer from anxiety, depression. Parkinson's disease, already discussed. Thyroid dysfunction, high prevalence of hypothyroidism in BMS patients. So what is the, how to go ahead in diagnosing these cases? Step one is taking thorough medical and drug history. That is the number one. Once the chief complaint has been told by the patient, thorough medical and drug history has to be taken. Identify the medications which result in burning in the mouth. Assess what are the characteristics of the pain, what is the impact of that pain or burning on the patient's life, as discussed in the previous slides. Examine the patient fully, look for any swelling, asymmetry, lesion, check for any parafunctional habits. That is also very important. So certain people, they have an habit of tongue thrusting and all. So they have a habit of keeping the tongue in the behind the lower teeth, or biting the tongue, or they are denture wearers, so ill-fitting dentures, that leads to. So we have to check, we have to take the history, we have to examine all these factors. And step two comes the laboratory tests. So the entire protocol has to be followed when we are advising the laboratory test for these patients. So third step, the neurological evaluation. So sensory, all the cranial nerves have to be examined properly, the trigeminal nerve, the facial nerve, and if felt, neurologist can be, we can refer the patient to neurologist also. So once the diagnosis, once we feel we have made a everything is fine, everything is normal, the tissues, the mucosa, there are no local factors, there are no systemic illnesses as such, but then still the patient has, in absence of any changes in the color or the consistency or the texture of the mucosa, patient experiences that. So patient is not wrong, may be suffering from burning mouth syndrome. And then what I believe is, before we prescribe any of the drugs, CBT, cognitive behavioral therapy, talking, counseling, discussing the disorder or the about to the patient, telling the problem to the patient in detail, uh, uh, is, I feel, is one of the most important steps. And then comes your some topical or the systemic drugs. uh, Clonazepam has been proven to be the most effective. Either if we talk of the topical agent or the systemic agent, we usually start off with topical clonazepam mouth rinses, It's given in the form of mouthwash. We can ask the patient to take the tablet. Mouth dissolving tablets are there in the market, so they can just swish it in the mouth and they can spit it off. No need to take it inside. They can spit it off. So that clonazepam taken in a topical form, in a rinse form, in an oral paste form, it helps in relieving the symptoms of burning mouth syndrome. Then is another anticonvulsant drug like gabapentin, 300 milligrams per day, alpha lipoic acid. Although these gabapentin, alpha lipoic acid, they have not they have shown results, but then they are not the, you can say, the promising, or you can say they are the definitive treatment modalities for this. Yes, it has shown results in certain patients. Pregabalin, amitriptyline, uh, SNRIs, then mandibular nerve block, stellate ganglion block, or maxillary and lingual nerve block with lignocaine or bupivacaine. Uh, the studies have shown that the pain have reduced after immediately the block has given, and low level laser therapy also has shown a good reduction in the pain in these patients. Cognitive therapy, as I said, has a significant effect in these patients. Psychotherapy, group cognitive behavior therapy. Topical capsaicin. It is not as such available in India. It acts as an analgesic. It's a red pepper, which a patient can use in the form of a mouth wash or a mouth rinse, can be used. Topical clonazepam already discussed. Low level laser therapy, gabapentin, CBT, paroxetine, and this SSRIs. All these, yes, they have certain side effects. Every drug comes up with certain side effects which one should be aware of as a doctor before prescribing it to the patient. So the clonazepam rinse has been the most consistent, evident, short term and long term in the treatment of burning mouth syndrome. Then capsaicin, and then benzodiazepine hydrochloride, which is available um, in the form of Culora mouthwash. But then benzodiazepine not really. It works if it is a if the patient has something. It's not. It doesn't work in BMS, actual BMS patients, but usually works in if the patient has. It gives a symptomatic relief. The patient has some lesions in the mouth. Aloe vera is not superior to the placebo. Bupivacaine, it's minimally clinically relevant effect. Alpha lipoic acid also lacks evidence versus placebo. Antidepressants, limited randomized control data is present for antidepressants. Anticonvulsants, gabapentin provides very low quality evidence. Benzodiazepines, systemic clonazepam is no better than placebo. There is always risk of dependence if you give clonazepam systemically. Cholinergics, very low quality evidence. Low level laser therapy is mixed results. CBT, very low quality, but then I feel it has, my personal experience says CBT has very good effect or very good this thing impact on the patient. Acupuncture, there are certain other alternative modalities like acupuncture, which shows limited evidence. All these things have been tried in patients with burning mouth syndrome. Physical barriers, tongue protector, people who have habits. So it very low evidence. Dietary supplements, low evidence. So, what is BMS? It's a condition, to summarize, condition characterized by burning pain of the lining of the mouth, either just affecting the tongue or more widespread in the mouth. What causes BMS? Changes happening in the nervous system when sensations in the mouth are passed to the brain, and hormonal changes may contribute to it. How do we diagnose? With a thorough history of the complaint, the medical history, a thorough oral clinical examination, and the lab tests. So, what are the key takeaways? Burning mouth syndrome is a disorder by exclusion. We have to exclude all local as well as the systemic factors, all exclude all possible causes of oral dysesthesia, any ill-fitting dentures, any oral habits, everything has to be ruled out, the psychological component. Burning mouth syndrome likely has neuropathic and psychosocial etiopathogenesis. And we, as an oral physicians or as a dentist, we are there to diagnose and we are there to treat or manage, we can say, to improve the prognosis of these patients. And these are the key references. Thank you.
Thank you, Dr. Dipti, sorry, pardon me on that, Dr. Dipti Bhatnagar. And it was really an enriching lecture because burning mouth syndrome, as I always call it, as a Pandora's box, because a patient just comes in with a burning mouth, but then when I look into the case history of the patient, we find that, there have been so many misleading, mislabeling
Yes.
that has converted a small little acute condition into a chronic case. And we always we blame, it's very easy to blame the nerves for everything. In females it's more than easy, like, okay, she is a female, that is the reason she's so irritable. So the label is very easy to give, but then it's very difficult and very it's almost impossible to treat these patients. The best is to manage these cases. And empathy, as you all say, as you said, in cognitive behavioral therapy, I am a big fan of cognitive behavioral therapy. When it comes
Yes.
to management, most of my patients, they think that I am talking, I get tired, by the end of the day. When I meet my husband, I'm always quiet for some time, and then he is like, how many orofacial pain patients you did, because he can understand, because I've spoken for almost 6 to 7 hours at stretch, because that is the amount of counseling these patients require.
They require.
One BMS case will take away at least 1 hour of your day in just talking to the patient to understand what are the overlaying, the Pandora's box I was saying. It just keeps on adding and adding. And as they say, absence of a pathology does not say that the patient's pain is invalid. So you have to be empathetic. And
And
thank you
that is
so
one
much.
reason they keep on shifting to from one doctor to
Yes.
another doctor, seeing all kind of specialists and all. And moreover, because of the cancer phobia in the mouth, why the symptom is not going,
Yes.
making them understand the issue that you're
Yes.
not wrong, you have an issue, you're not wrong, but then this is not
The whole
something not to be much worried about. Like
family suffers. Family
yes,
suffers with
family
it.
suffers.
It's not.
I
It's
had
not
one
just
patient yesterday. Literally, that patient was like, "My wife was into tears today afternoon." I said, "You should have brought her along with you to the clinic." She said, "You talked to her once." So she
Yes.
doesn't want to believe me. She feels I'm lying, that I don't have an issue.
Yes, easier said than done, and understanding, because at one point in time, those caregivers, they have a very big job at hand. Imagine being with a person. I am a chronic pain patient myself. So I always thank my husband and my daughter who tolerate me for most of the months, days in the month. I am in pain, and it's like I can understand how they are around me. Like, they're literally tiptoe, that they're literally walking. They're scared that something might trigger me and I might blast on them. So that is the condition with which the family life
Family.
changes, family changes. And thank you for bringing in such a difficult topic in such simpler way. And thank you for explaining that management protocol so easily for us to take care. But a very big disclaimer: these medications have a long-term side
Side
effects. So,
effects,
yeah.
yes.
So please be very, very vigilant when you are prescribing these medications. Not all the medications are under the preview of dentists in India. Orofacial pain specialty is still an upcoming field without a specialty status. So be
I
little
wanted to
vigilant.
discuss it in detail, but due to time
I
constraints and
understand.
all, it's a
No.
topic you can talk to us. You
Yes.
can.
So please be little vigilant when you're prescribing. Take a help of a physician friend. Always have a physician and a medical diagnostic person around with you who will guide you and prescribe it for you. So on that note, thank you, Dr. Dipti. And I'll like to welcome our next speaker, Dr. Anu Vijan here. Thank you so much, Dr. Dipti. Dr. Anu, are you there?
Yeah, hi.
Hello. Yeah. First, come. First, our normal clicking phenomenon. Okay, smile for the camera. 1 second, 1 second. Somebody has to be admitted. Okay, fine. Now smile again, ma'am. Okay. Dr. Anu, she is a professor in Department of Oral Medicine and Radiology at Mar Basilios Dental College, Kerala, and she's going to be talking about TENS, that is TENS therapy in orofacial pain and adjunct therapy. Before we begin our mandatory questions to all the dentists, I'm asking which is one thing or one mistake or one habit of yours that shaped you into becoming this orofacial pain specialist that you are today?
I was trained in the oral medicine department. So being a PG in oral medicine department, we used to get so many patients referred from all other departments because I am attached to a college also. So during my early practice time, I used to see so many patients, and I understood that the dental cause is not the only cause for facial pains. And that realization shaped my journey to orofacial pain. I started searching for all these things. I attended the course by Dr. Davis Thomas and also other mentors. So I'm so glad I have stepped into this field of orofacial pain, so that the happiness which we can bring in the patient's face once the pain is relieved is like a big blessing in our life also.
Yes, yes, yes. And one non-clinical skill and pain management specialist should always have. What would you say in one word?
In a single word, to say is to be a good listener.
Great. Wonderful. Wonderful, doctor. And you are going to be talking about a management therapy, and that is TENS. And can you start sharing your screen, doctor? Yes, I can see your screen, doctor.
So, good evening, all the delegates, distinguished speakers, everyone here in this platform of Orofacial Pain Congress. First of all, before starting the presentation, I would like to congratulate Dr. Sonal, Dr. Anwar, and all the organizers. I think this is the third consecutive year in a row we are having this Orofacial Pain Congress, right, Dr. Sonal?
Yes, madam. This is the third year.
Yeah. In the first year, I was just a delegate. I had presented when I was doing my orofacial pain fellowship, and in the next year, I was invited as a speaker. So thanks to you once again. And today, I bring greetings from my institution, Mabesilis Dental College. It's in a small city called Kotamangalam in the foothill of Munnar, where I used to see many orofacial pain patients who has shaped my knowledge, my expertise in management in the orofacial pain. And all these patients who come to my clinic with this pain, they say they need relief. They just don't want a prescription. They want relief from pain. So this pain is not just a sign or a symptom by the patient. It's a signal that sometimes need modulation, not just suppression. That's why I have the topic today, the TENS as an adjunctive modality in management of pain. So what is TENS? TENS, it's an acronym of the word transcutaneous electric nerve stimulation. It's a non-pharmacological method of pain control, wherein we are not giving any medication to the patient. We are just delivering transcutaneously, that is across the skin, we are delivering electrical current for elevation of pain. And before going into the detail how this TENS is acting in the patient, let's see when this usage of electric current for management of pain has started. So if you look into the history, we can see that in the 60th AD itself, this electric ray fish was used by ancient Greeks and Romans and Egyptians for management of pain. And it was Dr. John Wesley in 18th century who used the electric current for pain relief from sciatica and headaches. and kidney stones, gout, etc. And the modern concept of electric current for the usage of alleviation of pain was introduced by Dr. C. Norman Shaley, who's a neurosurgeon in America. And following which in 1972, this device, TENS device, was approved by FDA as a class 2 medical device. So that is why we have this. And how this TENS is going to act for relieving the pain is basically based on two theories, just for the theoretical knowledge, because this helps you to use which type of therapy or which modality of TENS we are going to administer to the patient based on the diagnosis we are coming to for the pain. So first theory is a gate control theory, and second one is the endogenous opioid theory. So the gate control theory, it was proposed in early 1967 by Melsack and Wall, where they explained the mechanism of action of pain. And to explain this theory in simple terms, I would say, just imagine the pain signals as some signals traveling from the periphery to the brain. So when these signals, before reaching the brain, it has to cross a gate, which is not always in an open position. It's in a closed position. So when this pain is being transmitted from your periphery and it is carried by the pain-carrying nerve fibers, which is a small diameter fibers, which we call the C fibers or the A delta fibers, the gate will remain open and the person will perceive the pain. But when the pain is being transmitted by the large diameter fibers, that is the A beta fibers, then the gate will remain shut and the pain is not perceived by the person, right? So this is exactly how the TENS is also working. So when we give the TENS will go and stimulate large diameter fibers, which will cause the closure of the gate, and thus the pain perceivance will be shut down in the patient's body. So that's why often the patient says, once we give the TENS machine or the TENS therapy to the patient, doctor, the pain feels less when the machine is applied on the patient's body. So this is an immediate onset action for the patient, and it can be used for the acute management of pain. Right. Now the next theory on which, the next theory on which the pain works is the endogenous, the TENS work is the endogenous opioid theory. So the endogenous opioids, as we all know, opioids are certain chemicals which are released in the body for relief of the pain, right? So what happens is that when the TENS is being applied to the surface of the skin, this will go and stimulate the nerve, and that will release certain endogenous opioids. Those are the painkillers like enkephalins, dynorphins, and morphines. And this will act in a certain level in a central nervous system, that is the periaqueductal gray and the rostroventral medulla, which you can see in the first picture. The PAG-RBM axis will get activated, which will go and inhibit the spinal cord, and the pain will not be perceived by the person. So this is like a TENS is going to stimulate the internal pharmacy in the body without even giving any drugs externally or supplementing any medications. Your body's pharmacy is being activated to stimulate the secretion of this pain-relieved opioids in the body, and thus it decreases the pain perceivance by the. That is the gate control mechanism and the endogenous opioid theory. Now we have another method which is being published in the Journal of Pain in the year 2003, where the research has found that the TENS also modifies the blood flow and vascular resistance in the patient. So we all know myalgias, the causes due to the decreased vascularity to the muscle, the hypoxia. So once this transient increase in blood flow is produced, the patient will have decreased pain, and also TENS has been shown to reduce the algogenic substance P in the spinal cord. So these are the modalities by which the TENS is going to help to relieve the pain in your patient. And this is the machine, the transcutaneous electrical nerve stimulation machine. So you can see the first one is the machine with several knobs on the surface, and the red and black colors are the channels where you connect these wires, which is again given these same colors. So you have to be careful to connect the same colors into the same knob. And these are the pads. You can see the black colored pads with the white border. These are the electric pads which is placed across the surface of the skin. And this white bottle has the gel. If you have taken or seen an ultrasonographic diagnostic modality. There is a gel which is applied over the surface of the electrode. The same kind of gel is being applied for the easy conductance of the electricity. And these are the straps, Velcro straps, which is supplied along with the machine for the positioning of the pads on the surface of the skin where you want to apply. So this is the closer view of the machine, which I use in my clinic. So these are the knobs. The first portion in this machine, we have a muscle stimulator also. So the first portion is the tense part where we have 3 knobs you can see and a small switch which is steel, which controls or which we can control the mode of delivery of the current. We can deliver the current either continuous mode or in a burst mode. That is the break. And the CH1, channel 1 is the controlling of the intensity of the first channel, and the channel 2 is to control the intensity of the second channel. And this is the frequency controlling switch. So in this machine, the frequency of the current delivered can be controlled from 1 Hertz to 150 Hertz. That's a larger frequency available. And this is the muscle stimulator, which is not very commonly used for pain management, but for the spasm of the muscles, we can use this muscle stimulators. So in the TENS machine, as I told, we have the frequency and the mode of delivery of the current. So the frequency can be varying from the low to high frequency, and the mode of delivery of the current can be from burst pattern, that is with the break period, continuous pattern, that is the same frequency delivered continuously, and a modulated pattern where the amplitude of the current is from low to high with the break period. So we can decide which kind of delivery has to be given to the patient. Now, after setting or after diagnosing the patient, we should select which kind of TENS therapy we are going to give the patient. Basically, there are 3 types of TENS delivery which we can give, the current delivery. The first one is a high frequency current with a low intensity, and that one is called as a conventional TENS. So the high frequency, we set the machine to 50 to 100 Hertz. I set to 150 Hertz in my machine because the highest frequency available is the 150 Hertz. And the low intensity. Now, how do we select the intensity? Is that we are giving the current to the patient which is strong but in a comfortable zone to the patient. Okay, so that is a low intensity, and we give it across the surface area where the patient is feeling the pain. And this conventional TENS is given or provided in such a way that it acts on the mechanism of gate control theory, and so it induces a fast onset of pain relief and a fast offset also. After removing the machine, immediately the action will be shut down. So that is the conventional TENS with a high frequency and a low intensity. So these kind of TENS therapy or the modality of delivery of electric current is given for acute pain cases or in myofascial pains where the patient immediately pain relief is required for the patient, and you are doing the magic in your clinic. The patient will be so much relieved. Now the next modality of delivery of current is the low frequency high intensity current delivery, which is called as the acupuncture like TENS. So here, as you can see, it is a low frequency, that is 2 to 4 Hertz of frequency current is set in the machine, and a high intensity is given, that is to a higher threshold. So the patient will have a little difficulty because of the high intensity, but again the frequency is low. And the advantage of this TENS is that it can be given in chronic patients because the onset will be little delayed, but the offset or the duration of the pain relief to the patient will be more when compared to the conventional therapy of TENS. So this low frequency, high intensity is given to chronic orofacial pain patients. And there is a third variety, which is the intense TENS, which is not commonly practiced by me. It is a high frequency and a high intensity current. So it is little painful or little irritating to the patient. But again, the advantage is that it has a rapid onset and a delayed offset. So in patients with chronic pain and also in acute pain conditions, we can deliver because the irritation or the discomfort which is perceived by the patient when you put the TENS in intense mode is high. I don't practice giving this intense TENS. I do give the conventional TENS modality to the acute pain patients, and for the chronic conditions, we do deliver the low frequency acupuncture-like TENS. So this is just a tabular column which I have compiled the high frequency and low frequency. Just if you want to take a picture, you can. So as I told, the high frequency is used for the acute conditions and the low frequency with the current of 1 to 4 hertz frequency. It is stimulating the motor level by releasing the endogenous opioids. And so the onset is gradual with a long-lasting effect. So we can give for the chronic pain conditions. Now this is just a video I have added for you to see how this TENS machine is being attached to the patient face. So this is a patient who had a myofascial pain in the masseter. So you can see I have put the Velcro straps. We first sterilize the surface of the skin. Look for if there is any sensitivity or any abrasions or open wounds on the surface of the skin. After that, we sterilize the electrode pads also. Then apply the gel and place the pads on the area where the patient is feeling the pain. And you can see the intensity knob is being controlled according to the tolerance capacity of the patient. And in my clinical practice, I give this conventional TENS therapy for a period of 20 minutes. And the frequency of delivery is like once in a week for maximum 3 to 4 weeks. So what are the clinical indications where we can give this TENS therapy is in the myofascial pain syndrome. In the temporomandibular disorders where the patient has associated muscle pains due to the TMJ condition. Not for the for the absolute TMDs, derangements, this is not indicated because that is not going to give any kind of relief to the patient. In cervicogenic pains, yes, we can give this TENS therapy. In acute pain conditions, chronic pain conditions, orofacial pains, where there is the conservative managements have failed or the drug sparing management was indicated or required or was asked by the patient, we can go for the TENS therapy. And as an adjunctive therapy, along with the other modalities of management like physiotherapy, the spins, pharmacotherapy, all invasive therapies, we can go with the TENS therapy also. But be careful, we can place the electrodes over the painful muscles or the trigger points like masseter, temporalis, upper traps, and the cervical muscles. And always when you are starting the TENS therapy, start with a low level stimulation with a conventional TENS modality. So there is a sensory level stimulation rather than the motor stimulation, and monitor the patient comfort throughout the session. You have to explain the patient what kind of feeling he is going to get when the electrodes are being placed and you are activating the machine. And be careful when you're placing it on the neck muscles, always go for a unilateral placement rather than the bilateral placement. So we don't have to administer close to any kind of transdermal drug delivery system the patient is having on the body. Do not place in the anterior neck where there is high proximity to the vital structure, especially the vasculatures, which can lead to bradycardia in the patient. In the eyes, that can cause the coagulation of the proteins. And avoid, as I told, in the bilateral symmetrical placement on the neck. Do not use high intensity stimulation near the cervical region because it causes the motor stimulation also. Should not be used while driving. So instruct the patient not to do, if you are advising for a home therapy with the TENS machine, ask the patient not to use it while driving. And the studies have shown that caffeine may inhibit the TENS effect. So when the patient is being given the appointment for the TENS therapy, ask the patient not to take a coffee 2 to 3 hours before your treatment. So the contraindications for your TENS therapy is the group of patients who are apprehensive. How much ever you are explaining to the patient is still apprehensive about the treatment, don't try to give this, because if something happens due to the apprehension of the patient, you are going to get blamed. So never in an apprehensive patient. In patients who have communication handicap or mental disability, who cannot communicate to you that the intensity when you are increasing, they cannot say to you properly that the tolerance is being exceeded or he's having some difficulty. Don't do in such patients. Patients with cardiac pacemakers, it's contraindicated. Patients with cerebrovascular diseases, epileptic patients where you can stimulate the vessels. In pregnant patients, there is no FDA approval to do the TENS therapy, but yes, the consortium physiotherapists, they say you can do away from the tummy region where you are not going to cause the muscular contraction, but it's always safe never to give in a pregnancy lady. In undiagnosed pain, you don't know what the cause of the pain is. Don't try to give TENS. In impaired sensation or an abraded skin with this having a high sensitivity, and as I told, this is not going to be effective in your TMD patients where there is a derangement or of the disc or any trauma. So the advantage of having this TENS therapy in your clinic is that you are going to deliver a non-invasive modality of management of pain. So that is a highly acceptable modality of treatment, especially in a chronic orofacial pain patient who have been running from clinic to clinic and who didn't get proper relief. This one is going to be a magic to the patient. This is safe and relatively fast in action in reducing the pain. And after the application, in my clinical experience, not a single patient has told any side effects. Patient can self-administer. You can ask the patient to do it at the home and adjust the dose according to the level of pain. And it's a relatively inexpensive one in our clinics. It's a one-time investment. So the disadvantage is that sometimes it can produce transient tingling sensation of transient paresthesia, which is temporary for the patient, but I never seen in any patients, as I told. And again, this is only an adjunctive therapy. This is not going to be definitive management for the pain. So always the proper therapy has to go along with this TENS therapy. And the variable patient response, because it will differ from one patient to another patient. The response for pain relief will differ. So we have to keep in mind all these things when you're going to administer the TENS to the patient. And risk if it is misused, especially in the anterior cervical region and the cervical region closer to the vessels. And always need patient compliance. That's why I told in apprehensive or uncooperative patients, never go for this because you need to give a repeated session. It's not like one session you give, the pain vanishes. It's not going to happen. So proper communication with the patient and a consent before, like any therapy, has to be taken before you give a TENS therapy also. So to conclude my presentation, I would like to say TENS is a linchpin in conservative pain management. It easily goes with other modalities of management, and it can be incorporated in your framework or in your treatment protocol as a first line of modality, because the patient comes and sits in your dental chair saying about pain, and you diagnose it's a pain arising from not the tooth, and it's creating some kind of muscular pains for the patient. You can give this TENS, which is going to bring a big smile on a patient's face. So it's a safe and adjunctive modality of management and has been proven to show increased efficacy. So with that, I conclude my presentation and I thank you all for your patient listening. Thank you. And you can contact me through my mail or my contact number for any doubts in usage of this TENS machine. Thank you.
Yeah, thank you, Dr. Anu. And there are a few questions in the chat box which you would love to address them to.
Yeah, sure.
This is a common question I would like to ask since it is in the chat box, but not so that the others don't miss out on it. So, any risk factors with the TENS therapy? You've mentioned the disadvantages, but is there any big risk factors which we need to consider as such for TENS therapy?
Yeah, that's what I told. If the patient is having any cardiac pacemakers,
okay,
if it's a fixed rate pacemaker, it is relatively contraindicated, but if it's not a fixed pacemaker, it's an absolute contraindication to use the TENS, and also in patients with CVA history and strokes.
Okay. And
otherwise, this has, in my clinical experience, as such, no risk has been seen for the patient.
Okay, fine. And one more question is, can you mention certain brands which would be more helpful or economical for the in terms of investment as a dentist? Because these are all equipment based. So can you specify certain brands or
brands I'm not very sure about, because there are many brands available. Many. And if you look in Amazon itself, you can see like starting from 1,000 rupees it starts, and we have one by the MedSkill which is available for 23,000 also.
Okay.
So that is a digitized one which is available for 23,000, and it itself modulates the time. You can set everything. We don't have to sit and monitor, look for the time. Every auto adjustments can be done in that machine.
Lovely, lovely, lovely. So on that note, doctor, thank you so much for bringing in this management modality. As you said, it's an adjunct therapy to all the other therapies. And first of all, the diagnosis should not be diagnosis of disclusion or inclusion. So best is to have a proper diagnosis before you start with some therapy. And as they say, diagnostic blocks or all these TENS therapies, they clarify your pathways, but they are a mistreated thing or misdiagnosed or mistreatment. When a treatment fails is more of a diagnosis rather than a failure. I always say that. So mislabeling a pain symptom, pain management which has failed, you should be treating it as a conclusion. Okay, this is not the therapy which you need to work on it, and adjunct therapies also can work. So thank you so much for bringing in this therapy. And on that note, I would like to welcome our next speaker, Dr. Sai Priya Tiwari. Dr. Sai Priya, you're there?
Yes, hello. Good evening.
Hello. Dr. Sai Priya is the only physician on today's panel, and she is not a dentist. Welcome to a dental world of dentist around you. And thank you so much for being a helpful partner in our management, patient care management and therapies. So thank you so much, Dr. Sai Priya Tiwari. She is a principal consultant and unit head pain management and palliative care at Max Super Specialty Hospital Dwarka, New Delhi. And she's completed her MB, she's an MD anesthetologist, and she is PDCC pain management. She's done it from SGPGIMS Lucknow. Pardon me, because we know about dental colleges, but when it comes to medical colleges, we are little ignorant. Pardon my ignorance, madam, on that. Fellow of Interventional Pain Practice and National Fellowship in Palliative Medicine from Kerala, and she has more than 25 national and international publications to herself. So a person who is well read and a person who wants to spread the knowledge not only amongst her colleagues but with dentists also. Congratulations on that, doctor, because it takes a different heart to come to such a forum and share your knowledge. As is our practice, I would like you to smile for the camera. Madam, can you go back little bit more, little bit? Yeah, now smile for the camera. Okay. Dr. Saipriya, as is the mandatory question I'm asking all the speakers. So one mistake or habit that change your practice totally. Like, I always talk about mistakes more because I believe mistakes are the ones that shape you.
Yes, so thank you so much for that kind introduction, Dr. Sonal, and thank you so much for having me on this forum. It's an absolute delight. And I've been listening to the past couple of lectures. They were very enlightening and very in-depth knowledge was shared. So really great to be here. It is my privilege and honor. And coming to your question, one practice or one mistake or one habit that has shaped my practice would be that I think over the years I have learned to prognosticate patients better. Meaning that if a patient, I am a chronic pain specialist, so I see pain from anywhere, head to toe. So I think it is very important to, in the beginning only, to give the patient very realistic expectations. Because there are certain pain conditions that we are able to manage by more than 9%, but then there are other pain conditions which we can manage only by 50 to 60 or 70%. So I think that expectation should be set from the first conversation itself. It goes a long way in achieving patient satisfaction, I feel. So that is something that I would say.
Thank you. That's a very apt way of putting it across, that expectation management says it all. As they say, over investigate, but under treat and under promise. So thank you so much. And one clinical or one non-medical book that has shaped your thought process or that you love to read.
Ooh, non-medical book. Okay, so I am a palliative care physician as well, because working in pain drove me towards cancer pain and thereby to oncology palliative care and end of life care. So there's a wonderful book called Tuesdays with Maury. And I think everybody should read it because it's about conversations between two gentlemen, and the elder one is a professor who's in his last days of life. So he really gives you a lot of insight into what is actually important in life. So the book is called Tuesdays with Maury by Mitch Albom.
Wow, lovely. I would love to read that.
Yeah, it's very nice.
Thank you so much. Can you start sharing your screen, madam? And the stage is all set for you.
I will do that, yes. So already we've had such wonderful discussions. I am not going to take a lecture. This is going to be more of a interactive session. Are my slides visible?
Your slides are visible, doctor. Go ahead. You can start with the presenter's mode.
Yeah. And are they moving?
Yes.
Yeah, okay. So, like I said, I am not going to teach theory. This is more of a kind of, an exercise for everybody to understand the different types of pictures that can present as an orofacial pain. although the topic is atypical facial pain. So moving forward, first, in my experience, I have seen that if anybody is having a facial pain or any pain in their oral cavity, the first doubt that comes to mind is that most probably this is a dental pain. So of course, that is always the first DD. If any orodental pathology has been ruled out, then and usually if the patients are describing sharp shooting pain over the face, the second most common thing or the other diagnosis that you think of is sometimes trigeminal neuralgia. So I know you have dedicated sessions for trigeminal neuralgia also, so I'll just be touching up upon this. I'm sure all of us are familiar with the entity called trigeminal neuralgia, in which the Gasserian ganglion or the ganglion of the fifth nerve gets affected and it starts firing on its own. And because of that, the V1, V2, V3, all dermatomes or all distributions can get affected and patients can have very severe neuralgic pain. If you do an MRI for such patients, usually you see a neurovascular compression. You may or may not see a neurovascular compression near the Gasserian ganglion. If it is present, the management is microvascular decompression. And if it is not there, or even if it is there and if the patients don't want to undergo surgery, there are interventions that pain physicians can offer. So there's something called as a Gasserian ganglion radiofrequency ablation, in which we take a needle to the Gasserian ganglion and with the tip of that needle, it has a thermal tip, so we can go in and burn the Gasserian ganglion and thereby provide pain relief to the patients. So trigeminal neuralgia as an entity, I'm sure a lot of you are familiar with. If we come to the definition, it is a disorder characterized by recurrent unilateral brief electric shock-like pains, which are abrupt in onset and termination. So there'll be a sudden pain and then it'll go away suddenly also. And it can be in either one division or more divisions of the trigeminal nerve. Now, so this is about the diagnostic criteria. I will not go into the diagnostic details of trigeminal neuralgia, but my point here is that trigeminal neuralgia is not the only neuralgia or only entity which can explain idiopathic kind of facial pain, because trigeminal neuralgia itself has a lot of subdivisions and subclassifications, and it can be due to multiple reasons. So the main purpose of speaking today is about other facial pains. So of course, if a patient walks into my OPD, I'm a chronic pain specialist. So most of you all are dentists. So if a patient comes to your OPD with facial pain, of course, like I said, you look for a dental periodontal pathology, or you'll ask for any nasal congestions, rhinorrhea, tenderness over sinuses, or any salivary gland disorders, because usually we have to initially rule out infection, trauma, or malignancy. But if we look at facial pain in totality, it can be because of musculoskeletal disorders like temporomandibular joint disorders. It can be neurovascular, like, for example, migraine, cluster headaches, or trigeminal autonomic cephalalgias. It can be vascular because of reasons like a giant cell arteritis or a carotidynia, or it can be neuropathic. One of the neuropathies I just discussed was the trigeminal neuralgia, and it can be because of other neuropathies of other cranial nerves as well. So with this, I'm going to come to some cases and we'll discuss differential diagnosis for those cases. So my first case for you all is a 55-year-old lady presenting with, so Dr. Sonal, can we make this interactive? How do I access the chat box here? Hello?
Yes, ma'am. What is the issue? We can hear you. We
Yeah,
can hear
yeah.
you.
No, so I was just thinking, because I will be asking cases to the listeners. So will they be able to respond?
No, there's a chat box, so maybe they can respond to the chat box. Is it a poll system you're using?
No, no, no.
No, then they're responding in the chat box. So,
Okay. So please, can you keep track of the chat box?
yes. No, you repeat the question, so they ask the thing again. Yeah.
So my first question is, we are discussing cases, okay?
Yeah.
So if we have a 55-year-old female the patient is telling electric shock-like shooting or stabbing pain in the right cheek and jaw in the V2, V3 distribution. Every episode of pain is short-lasting. It is lasting for less than 2 minutes, and it is getting triggered when the patient is brushing her teeth. In between these pain episodes, the patient is absolutely pain-free, and sensory motor examination is absolutely normal. So what would be your differential diagnosis in this patient?
So they are mentioning there are two responses for TN, and both the responses are for TN, trigeminal neuralgia, and nerve compression is also come up. One of them is mentioned as nerve compression.
Yeah. So as you will see, these final points are important in making the differential diagnosis, because two things here I'm saying, that in between the episodes of pain, the patient is absolutely pain-free. That means lancinating pain will come and go, but once that lancinating pain is gone, in between the episode, patient is absolutely pain-free, and there are no sensory motor deficits in this patient. So yes, you're very right in saying that the diagnosis is a classical trigeminal neuralgia. Now, coming to the second patient, same female, but in between the two episodes of lancinating or shooting pain also, there is some background pain present. That means that the patient is having intermittent lancinating pain over the face. Even when that acute episode goes away within few seconds, still some background persistent pain is there. Patient is not absolutely normal or pain-free in between the episode. Still, sensory motor examination is normal. Now, what is this? Any inputs?
We'll give them a 2 minute, 1 minute at least, because now it gets complicated here.
Yeah, it's going.
So
that
we've
is
got
my idea of explaining the atypical
now
entities that
we
exist.
have few responses saying idiopathic TN, TN
Yeah.
with continuous background pain,
Yes.
concomitant type pain, atypical neuralgia, and TN again. And yeah, I guess it's a muscle pain. Somebody's trying to evaluate it as muscle pain.
Yeah. So I think a lot of responses have come. It is great to see that. But the answer to this is that this entity is called, this is also trigeminal neuralgia, but this is, earlier it was called as atypical trigeminal neuralgia, but now the new ICHD-3 terminology labels this as classical TN with concomitant continuous pain. This is the actual definition as per ICHD-3 terminology. So as you can see, this is not classical trigeminal neuralgia. That is why when we read about TN, it is said that response to carbamazepine is almost diagnostic of a typical trigeminal neuralgia. These patients will not respond that well to only carbamazepine, and another antineuropathic agent usually has to be added to the management of these kind of cases. So this is the slight difference between case 1 and case 2. Now, in the same patient, this is the third case, sharp shooting pain, V2, V3 distribution, each episode short lasting. This patient has some background pain. So till now, we are at the same level as before. But this patient also has sensory loss over the V2, V3 distribution. So now, any guesses?
You are making their life miserable.
Yes, I am. You should tell me when to stop, because no, you should tell me when to stop, because these are really tricky situations. And
No,
but the fact
I'm
that I want to,
happy that we have you on panel, and this is the kind of education we want to uh, we are looking forward to actually. So we have
Chalo, I'm
refractory
glad to know,
pain.
because
Yeah, refractory pain, secondary TN, TN with central space occupying lesion, wonderful. Secondary TN, and yeah, and I think that's about typical neuralgia was for the
yes.
second case. Yeah.
So the first patient, very good. So I'm happy to see so many responses. So
Post-operative
my
neuralgia is also there, doctor. One more.
post-traumatic. Okay, interesting. Okay,
Lesions associated with
yes, that
nerve.
can be.
Yeah, that can be.
Yes,
They're all correct. Somewhere
they're all
5%,
somewhere
10%.
or the other. Yeah, you're all thinking. At least you're all thinking. So the important thing to highlight over here is that you have now differentiated that this is not a typical trigeminal neuralgia. There is some background pain which is persisting for the patient. And now, if we have moved ahead, that there is some sensory loss also. So the answer, now I'll give you more clues. Okay. So now this patient, if you ask the history in detail, this patient has a past history of recurrent optic neuritis, and MRI reveals features of multiple sclerosis. So this kind of a pain becomes what is called as a secondary trigeminal neuralgia. That means this is not idiopathic. This is a trigeminal neuropathy actually, or a trigeminal nerve condition, but it is happening as a part of a systemic response. So as you can see, the key over here is history taking. And as you will see in the further cases also, the key is taking history properly and doing clinical examination, because a small clue like some sensory loss over that area led us to ask for more history, led us to more, extracting more history from the patient of previous problems that they had. And finally, a diagnosis of secondary trigeminal neuralgia was made. So basically, I'll just come back to that. Secondary trigeminal neuralgia is when it is as a part of other disease spectrum, like typically multiple sclerosis. Now, again, I will come to a next case. Again, as Dr. Sonal is saying, I'm making it more and more complicated. But this is again the same patient, sharp shooting pain, episodic, triggered. Patient has already undergone a pain intervention before. So the patient already went to a pain specialist. They have undergone a Gasserian ganglion RFA before. In between, patient was pain-free for 5 months, and now a new pain has started. And now for this new pain, when carbamazepine was started, the patient is not getting any response. Patient has continuous background pain, patient has burning, and patient has a sensory loss also. I am not expecting you all to know the answer. If somebody answers, they should definitely get a prize for this. Neuropathic pain is the first one. Then PTTN. PTTN means what? Post-traumatic. I suspect that talking about post-traumatic. Post-traumatic. Yeah. Okay. So this, whoever is saying post-traumatic is probably closest to the answer. Yeah. Post-traumatic neuropathy, neuropathic pain, PTTN. Then excellent. I think your way of teaching is making their lateral wheels churn in a way. So it's allodynia. Okay, yeah, you are right, allodynia. But then someone is saying allodynia, and most of them have concluded to PTTN, that is post-traumatic neuropathy. This is excellent, because so now people are thinking, they have taken more history, and now you have realized that this patient has already undergone a procedure for the Gasserian ganglion. Right. So excellent. You all are absolutely correct in saying that this is painful post-traumatic trigeminal neuropathy, also called as anesthesia dolorosa. So I want to talk a little bit about this entity. So if you are getting a patient post a procedure for their nerve condition, and if they are having these kind of symptoms, what happens is that if you examine this patient, in the area of pain, they actually have a sensory loss. So as you can see the word anesthesia dolorosa, the anesthesia word means that there is no sensation, and dolo means pain. So they have pain. Now this kind of pain, important to know, this kind of pain is not a locally mediated pain. It is now a centrally mediated pain. It is now being mediated by the central nervous system. The story of the peripheral nerves is gone. This is a centrally mediated pain where patient does not have sensation, but still the patient has pain. So in this kind of a situation, the medications that will be used for this patient will be very different from the traditional medications that we used for a typical trigeminal neuralgia. We will be using different subgroup of anti-neuropathic medication, and most importantly, no pain intervention or no nerve block is going to help this patient, because they are already having sensory loss. So if a patient is having sensory loss, no nerve block or no Gasserian ganglion RFA is going to help this patient. Only properly titrated antineuropathic medications help this patient. So somebody is asking which medication, ma'am. So in a typical trigeminal neuralgia, we tend to use carbamazepine, oxcarbazepine, and this subgroup of eslazapine and eslicarbazepine and all these medications. But for this particular patient, a different subgroup like maybe amitriptyline or a pregabalin or a gabapentin will work better. But we will have to titrate accordingly. Now, okay. I'm moving on to the next case. This is a spot diagnosis. 75-year-old lady with vesicular eruptions over V1 distribution with persistent burning pain. Everybody will be able to tell me this one.
Yes, they are. They are
Because if
typing.
previously, yes, because if previously you have told postherpetic neuralgia, this is definitely a case of postherpetic neuralgia. This is also a kind of trigeminal neuropathy. This one is postherpetic neuralgia because, as you can see, healed lesions over the face. Coming on to the next case. Okay, so this one I have included here. Don't worry, very rare thing. Just I've included here because it is in the ICHD-3 list of conditions. But this is a 55-year-old male with constant unilateral burning pain in V1 distribution. Pain is getting aggravated by eye movements. There is some ptosis, meiosis, but no anhidrosis. There is sensory loss, and MRI is revealing a mass lesion in the maxillary sinus near the Gasserian ganglion. So I'm not going to ask you, this is a tough one. The answer to this is there is an entity called as Reader's syndrome or paratrigeminal oculosympathetic syndrome. So this picture is representing Reader's syndrome. So because here the pain is there along with some signs of, along with Horner's syndrome actually, this is ptosis and meiosis. So this one, if I go into the definition a little bit, is a constant unilateral burning facial pain with hyposthesia or dysesthesia in the distribution of the ophthalmic division of trigeminal nerve along with ptosis and meiosis. Usually it is caused by trauma, middle cranial fossa mass lesions, syphilis, sinusitis. So the whole point being that if this is the presentation, please investigate the patient further. They are definitely going to require an MRI of the brain. I'm not going into the details of this. Okay, coming to the next case scenario. 45-year-old male. Features of trigeminal neuralgia are present, but at the same time, they're having unilateral headache also. They're having stabbing pain in the eye also. The eye is tearing, some nasal congestion is happening. Parasympathetic features are happening. Pain is very, very severe. Any inputs as to what this can be? So we are moving a little bit into headaches. Very good. You guys know, पढ़े लिखे लोग हैं बहुत यहाँ पे. People have answered that this is a
Scunt or cluster headaches.
cluster headache situation. Yes. So the first part of the features are trigeminal neuralgia. The second part of the features are cluster headache, in which there is a unilateral headache with stabbing pain in the eye with parasympathetic features. A combination of this is called as a cluster tic syndrome. Excellent. So I'll tell you, I'll be honest, some people, if I'm presenting in a pain forum, a lot of time, people are not able to answer. So it's excellent that
I will take it as a compliment, and we being orofacial pain specialists, we are really working towards patient care. So please, yeah, hip hip hooray.
No, really. It's excellent. This is a cluster tic syndrome. Okay, another one. This all of you know because it was discussed in the lecture before, like in the session from 5:30 to 6 o'clock, that there is a postmenopausal lady anxious with dysesthesia, altered taste, and burning in the oral mucosa. Pain is recurring every day for more than 2 hours for more than 3 months. But on examination, everything is normal. This is, everybody knows. You are more familiar with this entity than I am. This is burning mouth syndrome, stomatodynia or glossodynia. So this has already been discussed in great detail by Madam earlier. And thank you very much. That was very educative for me as well. So what do I teach in this? But just to summarize that this is a small fiber neuropathy. And to manage this, we have to, of course, treat the underlying disease. And in idiopathic conditions, we have to manage with pharmacological therapy, typically tricyclic antidepressants, or maybe pramipexole or clonazepam. Next case. This is now here the distribution of pain has changed. Okay, so here the pain is recurring, paroxysmal, unilateral, lasting for few seconds. It is electric shock like, but it is not over the face. It is not in the front of the face. It is starting in the oropharynx and going into the ear. Usually precipitated by swallowing, coughing, talking, yawning, and sometimes can even be associated with cardiac arrhythmias. Anybody? Glossopharyngeal neuralgia, people have already answered. Very
Yes.
intelligent group of people, I must say. I'm
Yes,
really proud to be here.
compliments to my group. So thank you so
Yes.
much, guys, for making me proud. Thank you so much.
No, really. So this is now glossopharyngeal neuralgia. Excellent, because the pain is radiating into the ear. So it is intermittent lancinating pain, but it is in the ear. So this becomes a glossopharyngeal neuralgia. A lot of times it can be seen as an idiopathic condition. A lot of times it is seen because the styloid process is too long. Sometimes in cancer patients also with base of tongue malignancies, we see this kind of pain conditions. I'm not going into the details of the diagnosis. This is a picture showing a secondary glossopharyngeal neuralgia because of a large styloid process, also called as Eagle syndrome. So to manage glossopharyngeal neuralgia, we can easily access the glossopharyngeal nerve under ultrasound guidance, and we can go ahead and block it off. So that really helps significantly in managing this neuralgia. We can either simply give a local anesthetic or steroid, or we can go in and do a pulsed radiofrequency ablation of the glossopharyngeal nerve, and it gives good sustained pain relief. Okay, coming to the next case. 45-year-old lady with persistent, poorly localized, nagging, dull, aching pain in the nasolabial fold or one side of the chin, recurring daily for more than 2 hours a day for more than 3 months, but clinically the neurological examination is normal. Anybody? This is a little vague, but still, anybody, anything they have to say? Oh, I already told you the answer.
No, we missed it. Don't worry. It is PIFP temporalis.
Yes. It is no, it is exactly persistent idiopathic facial pain, also known as atypical facial pain. So like I said, although the topic of today's lecture was atypical facial pain, but I have now only reached actual atypical facial pain or idiopathic, because for this kind of pain, it's very vague. There's no localization. There is no concept of dermatomal pain. It's not dermatomal. It is poorly localized. It's anywhere, happening chronically. All examination is normal. No reason is found. This is known as idiopathic facial pain or atypical facial pain. Now, there's a central neuropathic facial pain, which can be caused by lesion or dysfunction in the central nervous system. And there are two entities recognized by ICHD, which can be a part of central neuropathic facial pain, which is central neuropathic pain attributed to multiple sclerosis or central post-stroke pain. So these are also other entities which can present as a atypical facial pain. This one also, again, another one which is important to identify, that this patient is having right temporal pain for 2 weeks associated with allodynia. This patient is having jaw claudication. Yes, already answers are coming in. Very good. Giant cell arteritis. There's ESR is raised. Constitutional symptoms are present. And patient is febrile, and there's imminent danger to loss of eyesight. Very good. This is a giant cell arteritis case. Very important to identify because it has to be managed urgently with steroids. Otherwise, it can lead to loss of eyesight for our patients. So I think if anybody with a facial pain comes to any of you, they are in safe hands. They will be managed very well. And other causes of facial pain, of course, cancer pain is a large component that can present as a facial pain. For me, the setup where I'm working, 50% of my patients are coming from oncology, so I'm seeing a lot of cancer-related facial pain. Occult lung neoplasms can also cause some pain radiating into the face. Coming to just a word about primary headaches, I've just included this here because headaches also sometimes they radiate to the hemifacial area. So I see that you're all familiar with cluster headaches. There's also something called as a tension headache, although in that headache will be only in the upper part, like on the forehead, like a band. And migraine patients also sometimes may have a component of facial pain. Not going into the detail, but there is a subsection of headaches called trigeminal autonomic epiphylalgias, which include cluster headache, paroxysmal hemicrania, sanct hemicrania continua, and probable TAC. They differ from each other. Basically, their symptomatology is pretty much similar, but it varies depending on the frequency of attacks and the duration of each attack. So in a cluster headache, usually the duration of attack is between 15 to 120 minutes. As it gets shorter and shorter, we move to paroxysmal hemicrania, which is 2 minutes to 45 minutes, sanct, which is very, very short duration in seconds, and hemicrania continua is a fluctuating continuous pain with superimposed attacks. So this is, I think, a detail. So trigeminal autonomic epiphylalgias is a whole different topic, but just to familiarize you with these conditions, that these can also present as a facial pain. So I think I have pretty much named a lot of different reasons or causes of facial pains that can present to our clinics. TM joint disorders I have not touched upon because I'm sure somebody is going to be teaching us that in detail. Now, as an interventional pain specialist, what do I do for these patients? I can either manage by using conservative measures, or I can start these patients on anti-neuropathic agents, or I can offer them some nerve blocks. So what are the nerve blocks that I can offer to these patients? Depending on the diagnosis and depending on the distribution of pain, we can do a Gasserian ganglion block. We can do a sphenopalatine ganglion block. Sometimes we can even do a stellate ganglion block for these patients. And for glossopharyngeal neuralgia, like we discussed, we can do a glossopharyngeal nerve block. And very, very important, one must have a good sense of clinical sense of diagnosis, because if I feel that I can manage the patient on my own, great. If I feel that a super specialist referral is required, it is a smarter thing to involve colleagues early so that the correct diagnosis is made and the correct treatment is delivered to the patient. So very, very important point to remember here, that always remember to include a multidisciplinary kind of team if you really want the best outcome for your patient. So these pain interventions that we do, just a word about them. So whichever nerve that we find is could be the culprit, or the blocking of that nerve could give pain relief. There are three things that we can deliver to that nerve. We can either give a local anesthetic with steroid. So usually with that, the relief in pain lasts for 3 to 6 weeks. Or we can give absolute alcohol to those nerves, whereby the relief is 3 to 6 months. Or we can go ahead and do a radiofrequency ablation of those nerves, in which the pain relief is much better and sustained and longer for up to 9 to 12 months. So in radiofrequency ablation, we use needles that have a small tip, which is an active tip that delivers thermal energy near the nerves, and they can be kind of burnt. So this is just a picture of a patient who is undergoing a Gasserian ganglion RFA. As you can see, it is a percutaneous intervention using just a needle. And this needle is going into the middle cranial fossa towards the Gasserian ganglion. It can be done under local or under mild sedation, and patients get good relief. So usually we do it under fluoroscopic guidance, and we have to use fluoroscopic pictures and landmarks to reach the Gasserian ganglion. So this is my needle going to the Gasserian ganglion, and after this I performed a RFA for the Gasserian ganglion. Now another ganglion that I was mentioning here is the sphenopalatine ganglion that we can target, which is in the pterygopalatine fossa. So I want to share one case with you that was a 75-year-old lady who presented to me with severe left-sided facial pain since October 2021. She had consulted me at that time also. And then after that, she had gone to multiple other doctors, but then she came back to me. And pain had started with a perioral tingling, and it was a shooting kind of pain also. So it was a combination of the tingling and shooting. But over the time, the patient had taken multiple courses of different anti-neuropathic medications, and the nature of pain had changed, but it was still a nagging, burning, shooting pain. Patient had been extensively evaluated under neurology, internal medicine, and dental departments. Various investigations had been done. MRI brain was absolutely normal. MRI face with contrast was normal. MRI cyalography was normal. And there was a whole folder of other tests which I have not written here, but all normal. And this patient also had some dysgeusia and heaviness over one half of the tongue. So I did not know, honestly, what to do. But my diagnosis for this, after having seen that the patient has gone to multiple people with no diagnosis, then this becomes idiopathic atypical facial pain for me. And for this patient, I went ahead and did, because the symptomatology was overlapping, because there was shooting pain also in the V3 distribution and perioral tingling also. So I went ahead and did two blocks in this patient. I did a Gasserian ganglion RFA as well as a sphenopalatine ganglion block. And it's God's grace that she came to me 3 days later with more than 90% relief in her pain. So I think this is how we learn and this is how we grow. And to conclude, I think I will say that facial pain is a very complex disease. Multidisciplinary management is a must. And I will highlight again, as you saw by the various cases that I shared, that history taking is the key. Meticulous history taking is the key to reach the correct diagnosis. Always rule out orodental pathology. Of course, you people know this better than anybody. Always perform cranial nerve examination. If you have any suspicion, advise an MRI of the brain early, and choose your patient for intervention very, very carefully. So I think that is the message that I would leave you all with today. And thank you very much. You all already know quite a bit. So yeah, that's it from my side.
Thank you, Dr. Saipriya. And it was really a pleasure having you and your way of flashcard type teaching. I loved it. And this actually, see what happens when you say it, when coming from a medical fraternity to a dentist talking about pain management, I take it as a pride moment for us that many of our participants knew something. So my idea or theme behind organizing such conferences was to create awareness amongst dentists what not to do and where to refer the case and when to stop intervening or stop to do that extraction or hold back before doing certain invasive treatment plan which will not help the patient and more so have a peaceful night sleep. So for that pain management care, so most important is to diagnose the case well. And thank you, Dr. Sai Priya. And I guess this was your first year with our Congress, but I'm sure now you'll be an integral part of, since our participants have also obliged you with their active participation. And there is a question also for you in the chat box that can, ma'am, alcohol blocks are still being used. She's questioning you on that.
Yes, alcohol blocks are still very much in use, although the better way of blocking nerves is now a radiofrequency ablation. But in some situations, alcohol can be used, especially in resource limited settings. Alcohol is being used. It is not being used for no longer for Gasserian ganglion and all that. No, not in very delicate areas. No, but for example, for upper abdominal pain, for celiac plexus blocks and all, we are using alcohol.
Yes, thank you, Dr. Sai Priya, and I hope you have enjoyed this session. And if there are many questions still popping in, so you can just answer them in the chat box. Which medication you found to be best for a typical facial pain, amitriptyline, gabapentin, or any other?
I think it varies from patient to patient. You have to sometimes give them a trial. But yes, amitriptyline, I like amitriptyline personally.
Okay, we all know the reason for that, but then let's discuss it. That's a separate I think a thesis topic in itself. Why amitriptyline over
Yes, yes,
gabapentin?
yes, anti-neuropathic medicine. Taking
Yes.
this on a different topic in itself.
Yes, thank you so much, Doctor. It was really a pleasure hosting you today, and looking forward to your inputs in future also. Thank you so much. Okay,
Great.
and if there are any questions in the chat box, if you want to chat with our audience there, you can just drop in the chat box. On that note, we would like to conclude our day one because Dr. Dipti Bhatnagar has already presented her presentation earlier on since Dr. Tara was under the weather. So we would like to conclude day one, and on as a moderator, as a organizing secretary, I'm more than honored to have such a lovely audience, such great speakers. You know what? I call myself privileged because sitting here, I'm listening to each and every speaker, each and every interaction from the participant, and I am learning here. The learning curve for me is great, and thank you so much. I say I keep the conference for myself to learn. So that's the best way I can put it across to. Thank you so much. As we conclude our day one of International Orofacial Pain Congress Season 3, it has been an insightful discussion, shared learning, and we thank all our participants, all our enthusiastic speakers, mentors, and the zeal with which the participants were interacting. And I'm sure tomorrow it's going to be a hell of a marathon. I think we are starting at 9:30 and the day will conclude at 7:30. And if all my speakers keep that promise of 22 minutes to 25 minutes of presentation time, I think I will have a good night dinner tomorrow also. So thank you all my speakers for finishing their presentation in time. And yes, the party is on me, as I had mentioned in the group also. So thank you so much for all that. Day one has laid a strong foundation, and we look forward to welcoming you back tomorrow with renewed energy. Keep a water bottle, keep tiffins there, and no mothers are going to be cooking tomorrow, so it's going to be take away for all the participants. Parties on me, as I had said. So please see to it that you stick around because tomorrow's day promises another section of orofacial pain practice that is totally out of the world. And Dr. Sai Priya, since you enjoyed today's presentation, please join us tomorrow also. We thank our patron, Dr. Rangarajan sir, who obliged us with joining this inaugural ceremony in the first half of the day. Sir, we would like you to come tomorrow as well, and all the other speakers and participants, please join us tomorrow. And we would like to thank the organizing team, Dr. Nurul and his technical team also, who have been very actively helping us around and seamlessly seeing to it that all the links and everything is provided to all the participants and the speakers. YouTube link is shared in the chat box earlier on by me. Please have a look at it. Tomorrow's session starts at 9:30 a.m. and I want you all here by that time because the first session itself is by Dr. Rangarajan sir, our patron for this congress, and he's going to be talking about orofacial pain and sleep disorders. It's a session to look forward to because Dr. Rangarajan, whenever he speaks, it is like pearls of wisdom. You need to just collect it. So I would like to conclude our day one. The YouTube link is shared. If you all want, after this concluding, I will share it again with you all. But check my earlier messages. I've already shared it in the chat box. And we have Dr. Soumyanathan, Dr. Ajay Nayak, Dr. Sumit, and so on and so. Dr. Ratin Das. Everybody is there. So please join us tomorrow. And thank you all, everybody. Dr. Nurul, are you there, or should I conclude the day one? Yeah, I think.
Yes.
Yeah.
No. Yes, Dr. Sonal, thanks for doing hosting this whole session and all. And I just came just 10-15 minutes back, and I saw the interaction with Dr. Sai Priya, and it's very privileged that the audience, the Iopconians who are there in our group, are very familiar about the cases and all, and they are excellently diagnosing, giving the good. Differential diagnosis of all the cases. I think 10 cases mentioned by Dr. Sai Priya. So it's really, the objective of this program basically is to make them aware how to, relieve the pain of the patients and all. And as Dr. Sai Priya told, that all the cases should be deal with interdisciplinary. So we should not hesitate to consult our colleagues and the other medical fraternity for correct diagnosis of the case. And also we should take care of the intervention as well, because the intervention is very important. So we should have a proper diagnosis, and diagnosis comes when we get a proper the history actually. So history is a key for going to the proper diagnosis. So with this note, I think over to you, Dr. Sonal. It's a great day today, and we are hoping that the next 2 days would be further more mesmerizing, more active, and more energetic. And with this note, over to you, Dr. Sonal, and we'll join tomorrow, I think 9:30 in the morning.
Yes, yes. Thank you so much, everybody. And Dr. Nurul is getting more and more greedy. I think he wants more and more participation from the active participation. So I think we will have a special gift for the most active participant in the chat box also. So that the gift is again on me. So please join tomorrow, and looking forward to an enriching session tomorrow, and active participation by all the participants. Thank you, Dr. Nurul, for this platform, and thank you everybody for such a lovely day today. And enjoy your rest of the day, and have a good night. Take care. Bye.
Bye, everybody.
Bye.